Good morning. Subcommittee can now please come to order. Someone once said, I'd like mornings better if they started later, and amen to that, especially as a Californian. But I truly appreciate the effort that everyone has made to be here for a somewhat unprecedented 8 o'clock in the morning hearing. Although, as I said, as a Californian, my clock still says it's 5 o'clock in the morning. But seriously, when it comes to the topic at hand, there's no better time than right now to discuss it. Today, prescription drug abuse is a deadly serious and rapidly escalating problem all across America. We have an obligation to tackle it head on. The chair now recognizes herself for an opening statement. Since 2003, more than 5,000 U.S. servicemen and women have died in Iraq and Afghanistan. As Americans, we celebrate their lives and we mourn their deaths. They will always be remembered by a grateful nation. Yet today, there is a mostly forgotten war also being fought right here at home, in both small towns and large cities all across the United States. This costly and rapidly escalating struggle against prescription drug abuse and addiction is expected to claim the lives of some 30,000 Americans this year alone. For the most part, this battle is being waged in remote outposts of the human mind, where scientists now tell us that childhood trauma, genetics, mental disorders, stress, thrill-seeking social pressures, severe pain from injuries and illnesses, and yes, the horrors of combat, all contribute to devastating addictions, which in turn all too often lead to tragic and avoidable deaths. But what's even more insidious is the way these powerfully addictive drugs quickly turn people without any real emotional or physical problems into desperate people suddenly facing life or death problems. Few things are more destructive. According to the Centers for Disease Control, drug overdose is the second leading cause of accidental death in the United States, in large part due to prescription drug abuse, and the problem is growing every single day. According to a recent national survey, some 7 million people aged 12 or older regularly abuse prescription drugs, and there are approximately 7,000 new abusers every single day, many of them teenagers and young adults. That alarming trend is taking a huge toll on society. Today, the abuse of prescription drugs, especially painkillers, stimulants, and depressants, is the fastest growing drug problem in America. As someone who has been deeply and personally affected by this issue, I hope today's hearing will lead to a better understanding of the enormous scope of this problem, the staggering costs, both emotionally and financially, that it imposes on families and communities, and the need for a greater sense of urgency as a nation in addressing it. I believe one critically important first step is to do a better job of monitoring and limiting access to prescription drugs containing controlled-release oxycodone hydrochloride, including the popular painkiller OxyContin. Originally, OxyContin was intended to be prescribed only for severe pain as a way to help patients dealing with late-stage cancer and other severe illnesses. Today, however, more and more people across America are being prescribed OxyContin as well as other generic oxycodone drugs for less severe reasons, clinically known as moderate pain, greatly expanding the availability and potential for abuse of these powerfully addictive narcotics. For people all across America, prescription drug abuse is a day-to-day struggle. Over time, it destroys families and wreaks havoc on communities all across the nation. Someone with a toothache or a sore back should not be prescribed a potentially addictive painkiller. I agree that expanded public education plays a role in addressing the problem, but we're not going to make any real progress until we limit access to these powerful narcotic drugs and ensure that only patients in severe pain can obtain them. The pervasiveness of prescription drug abuse made national headlines recently when federal, state, and local law enforcement agencies, led by the Drug Enforcement Agency, cracked down on so-called pill mills in Florida, resulting in dozens of arrests, including 5 doctors. Congress needs to make it much more difficult for these rogue pain clinics to operate, and we should treat offenders like any other street drug dealer. By better coordinating the efforts of local, state, and national agencies, and by reducing the supply of highly addictive opioid painkillers, I am convinced that we can eventually save thousands of lives and spare millions of families from the headache and heartache of addiction. A recent Denver Post article highlighted why these powerful drugs are so attractive to thieves, drug dealers, and unscrupulous doctors. According to the Post, OxyContin costs $1 per milligram on the street and comes in doses ranging from 15 to 80 milligrams. So a dealer selling 1,000 tablets can make up to $80,000. What does that mean in human terms? Well, a recent report by the National Institute on Drug Abuse has found that nearly 1 in 20 high school seniors have reported abuse of OxyContin. And yet another disturbing report by the Substance Abuse and Mental Health Services Administration shows a staggering 400% increase in admissions of people aged 12 years and older for treatment of prescription drug abuse between 1998 and 2008. Clearly, we have a daunting challenge in front of us. I'd like to thank all of our distinguished panelists, especially DEA Administrator Leonhardt, ONDCP Director Kurlikowski, Governor Scott, and Governor Beshear for their personal commitment to the important issue. If we're going to win this fight against prescription drug abuse, we must all serve as the soldiers. The gentleman from Texas is now recognized for 5 minutes for an opening statement.
Madam Chair, thank you very much, and thank you for calling this most important hearing and for inviting so many experts that will create our 4 distinguished panels of witnesses. I need to apologize because I will be absent for part of the hearing, hopefully, and will be returning, but at around 8:30, I will have to go to another presentation, then hopefully come back, but we should have some members on our side of the aisle. I also wish to extend the apologies of ranking members Butterfield and Waxman, who are disappointed that they cannot be here at this time, obviously due to a conflict in commitments. According to the 2010 National Drug Control Strategy, the fastest growing form of substance abuse in the United States is the non-medical use of prescription drugs, including opiates, relievers, tranquilizers, sedatives, and stimulants. Under the careful supervision of a doctor, these medications can alleviate severe pain or help those suffering from mental disorders like psychosis, depression, anxiety, insomnia, or attention deficit hyperactivity disorder. Teens and young adults are increasingly susceptible to prescription drug abuse. 7 out of the top 10 substances most abused by young people are prescription medications. Like their older counterparts, teens most frequently obtain non-medical pain relievers, tranquilizers, and stimulants from a friend or a family member. Despite popular misconceptions to the contrary, research indicates that even teens and young adults misuse prescription drugs not just to get high, but for a variety of reasons. The Partnership for a Drug-Free America answers that teens do so to party, to get high, and in some cases, but also to manage or regulate their lives. They're abusing some prescription stimulants to give them additional energy and ability to focus when they're studying or taking tests. They're abusing prescription pain relievers and tranquilizers to cope with academic, social, or emotional stress. Many teenagers draw key distinctions between these drugs and illicit street drugs, characterizing their use of prescription drugs as responsible, controlled, or even safe. Researchers have concluded that the growing popularity of prescription drugs also reflects the perception that these drugs are safer than street drugs. There are several programs at the federal, state, and local level that seek to curb prescription drug abuse and diversion. I look forward to the testimony of our witnesses so that we may determine what is working and what more can be done to stop the growing problems. And Madam Chair, unlike many of the hearings we have, and we have such contentious differences of opinion, I don't think we're going to have that today. I think we're just going to try to identify what works and that we move forward and lend the assistance at the federal level to everyone out there in attempting to curb a very serious problem. And I yield back at this time.
I thank the gentleman for his words and for the spirit with which he said them. And now the chair recognizes Mr. Pompeo for 1 minute.
Thank you, Madam Chair. I just briefly wanted to say thank you for holding this hearing. Thanks for bringing attention to this incredibly important issue. I'm the father of a 20-year-old son. I know the kinds of things he's seeing at Kansas University. I know the kinds of challenges that young people have with these, and I look forward to your testimony this morning so that we can get the facts, learn a little bit about what works so that we can develop good federal policy that will minimize the risk from this very real concern that I think lots of parents have all across the country. So thank you all for coming this morning. Thank you, Madam Chairwoman. I yield back the balance of my time.
I thank the gentleman, and the chair recognizes Mr. Guthrie for 1.5 minutes.
Thank you, Madam Chairman. I won't take too much time because I'll speak a little later when our governor's here in the next panel. But I just want to thank you for bringing attention to this issue. It's important. It's important in my state, like all states, but we particularly have a problem, and we are looking forward to the next panel. But I just wanted to say thank you so much for having this hearing today. I yield.
Thank the gentleman and recognize the gentleman from Texas, Mr. Olson, for 1.5 minutes.
I'm pleased to be here early this morning and thank the chair for her leadership in holding this hearing to shed light on the problem of prescription drug diversion and abuse. I know this is an issue that is greatly important to the chair, and I commend her on assembling an impressive group of witnesses. Prescription drug abuse in America is not an issue we should take lightly. As a parent of 2 children, it's very concerning to me to see statistics showing that on a daily basis, 2,500 American teenagers are trying prescription drugs for the first time. 2,500 per day. The vast majority of these teens are getting drugs from their own house, taking them from their parents' medicine cabinet and using them or giving them to friends. Given this, it's so important that parents are educated about the risks of prescription drug abuse in addition to knowing about and utilizing drug disposal and take-back programs. I thank the chair for her commitment to America's youth. I look forward to hearing from witnesses. I yield back.
I thank the gentleman, and the chair recognizes Mr. Harper for 30 seconds.
Thank you, Madam Chair. And I certainly welcome the witnesses. It's quite an impressive lineup. We look forward to hearing what each has to say today. This is an important issue, and it has devastated families that I know back home. Spending years as a prosecutor, you see what it does to many unintended victims in this. And I just look forward to looking for solutions and ways that we can solve this and help these families. And I want to thank you, Madam Chair, for holding this very important hearing.
I thank the gentleman, and everybody's so happy this morning. The chair recognizes Mr. McKinley for 30 seconds.
Thank you, Madam Chairman. I join that. I thank you for holding this hearing this morning on this topic. As a father of 4, but a grandfather of 6, and I see what they're going to be facing. I saw what happened in our society back in the 60s. It wasn't pretty, and what these kids are facing today is shocking. My wife is a critical care nurse and works in the emergency room of a hospital, and she tells me time and time again of the horrors of so many people come in that have abused the drugs and what it's doing to our nation. So I welcome you and thank you very much for holding this hearing so that we can learn more how we can address this and save our next generation. Thank you very much.
I thank the gentleman, and the chair is pleased to recognize the vice chair of the committee, Ms. Blackburn, for 30 seconds.
And thank you, Madam Chairman. Welcome to our witnesses, and thank you all for being here with us today. There are 3 points that I think that as we work through what is an emotional debate that we need to be thinking about. First, to what extent should duly licensed prescription drug manufacturers be required to spend time, money, and resources on trying to envision every new way that their product might be abused? Secondly, if we begin to restrict the approval of new prescription drugs, what impact will it have on patients who desperately rely on them to cope with debilitating pain and are just trying to make it through another day? And perhaps the most important question is, how do we deal with personal and parental responsibility? And I yield back.
I thank the gentlelady, and the chair recognizes the gentleman from New York, Mr. Towns, for 5 minutes.
Thank you very much, Madam Chair. Let me thank you and Congressman Butterfield for having this hearing, and I also want to thank Congressman Gonzalez for filling in on his behalf. This is a very serious issue, and I am very pleased, however, that a number of provisions in the recently enacted Patient Protection and Affordable Care Act could yield some very positive results in our efforts to curb this growing problem. We must educate families about the dangers of loose prescription drugs in their households. We must also utilize other relevant federal laws and procedures in order to safeguard against prescription drug diversion. Some of these safeguards include a recently proposed risk evaluation and mitigation strategy. If implemented by the FDA, this strategy would train prescribers, catalog patient information, and administer periodic effectiveness assessment tests. Other safeguards would involve improving the communication abilities of our law enforcement officials, doctors, pharmaceutical dispensaries, so that frequent abusers can be brought to justice. Tackling the growing danger of prescription drug abuse will require bipartisan support. And that's the reason I was happy to hear the comment made by Congressman Gonzalez, that we are all on the same team when it comes to these kind of things and when it comes to protecting our young people. And I'm really happy about that. This public health issue requires the input and resources of all relevant stakeholders to ensure this problem is fully addressed. This is not one that we should get involved in the blame game. I think that there's enough blame here for everybody to share. I think it's time to come together to see in terms of what we can do on both sides of the aisle. Of course, every stakeholder that's involved in this issue, because this is an issue that if blame would solve it, then it would not even be here, because all over the years that we've been complaining about it. But I think the time now has come when we must roll up our sleeves and together work to see what we can do to be able to curtail the fact that, especially with our young people, who the numbers seem to keep going up and up. I look forward to this hearing from our witnesses today and working with my colleagues to ensure Congress plays a vital role in protecting families from the growing danger of prescription drugs. And let me say to the chairperson that I really, really appreciate her involvement here, and hope that we will continue to work together to see in terms of what we might be able to do to protect the lives of many of our young people who've gotten involved in this. And of course, I think that we can do a lot better. Thank you very much. I yield back.
I thank the gentleman. And now to move to the panel, we have the first panel, one of four that will be before us today. Each of the witnesses has prepared an opening statement that will be placed into the record. Each of you will be given 5 minutes to summarize that statement in your remarks. On our first panel, I'm honored that we would have these two distinguished witnesses, the Honorable Gil Kurlikowski. When I first met him, I couldn't say the name, and so I've come a long way. Honorable Gil Kurlikowski, Director of the Office of National Drug Control Policy, and the Honorable Michelle Leonhardt, Administrator of the Drug Enforcement Agency. Good morning to both of you, and thank you for your hard work, and you will each be recognized for the 5 minutes. You probably know the drill. There are lights over there, and as they're green, you are well on your way. When you see the yellow light, you're down to the wrap-up time, and when you hit red on the light, if you could then sum up your comments, and we will then move on to the next witness. So, Director Kurlikowski, you may begin with your first 5 minutes. Thank you.
Well, thank you, Chairman Bono-Mack, and thank you, Ranking Member Gonzalez, and the distinguished members of the committee for the opportunity to address prescription drug issues. I really applaud the committee's focus on this topic. Prescription drug abuse has been a major focus since my confirmation, and I've directed that the National Drug Control Program agencies address this epidemic in our country. Let me pause for a minute. As a longtime police chief in Seattle for 9 years, I paid attention to what caused harm in my community. Quite frankly, the abuse of prescription drugs wasn't on my radar screen, and quite frankly, I believe that around the country, this has not received the attention that it needs. Well, as the President's chief advisor on drug policy, this position demands that I raise public awareness and take action on drug issues affecting the nation. The efforts in the President's drug control strategy are balanced. They incorporate new research, evidence-based approaches to address drug use and its consequences. In 2008, over 23 million Americans ages 12 or older needed treatment for an illicit drug or alcohol use problem. However, only 11% received that necessary treatment for that substance use disorder. Well, today I'm here to talk about prescription drug abuse. Prescription drug abuse, as was mentioned, is the fastest growing drug problem in the United States, and it's categorized as a public health epidemic by the Centers for Disease Control and Prevention. And in recent years, the number of individuals who for the first time consume prescription drugs for non-medical purposes was similar to the number of first-time marijuana users. The 2010 Monitoring the Future, a national survey on youth drug use, found that 6 of the top 10 substances used by 12th graders were pharmaceuticals. We've also seen a 4-fold increase in addiction treatment admissions for individuals primarily abusing prescription painkillers. That was from 1997 to 2007. And even more alarming is the fact that over the last 5 years, emergency room visits linked to misuse or abuse of pharmaceuticals has nearly doubled. And at the same time, emergency room visits for illegal drugs like heroin and cocaine remained relatively flat. Furthermore, deaths from prescription drugs are increasing at a staggering rate, and state data show that 7 people in Florida, 4 people in Ohio, 3 people in Kentucky die every day from an unintentional overdose. The latest national data found that more than 27,000 Americans died from unintentional drug overdoses in 2007. Prescription drugs, particularly the opioid painkillers that were mentioned, are considered major contributors to the total number of drug deaths. And in 17 states and the District of Columbia, drug-induced deaths are now the leading cause of injury death. There are 2 unique reasons for the growth of the prescription drug abuse: easy accessibility to these drugs and the perception of risk. And for instance, persons age 12 or older who used pain relievers non-medically in the past year between 2008 and 2009, nearly 70% obtained the drug they abused from a friend or a relative. And research shows that because prescription drugs are manufactured by reputable pharmaceutical companies, they're prescribed by licensed clinicians, they're dispensed by pharmacists, they are perceived as safer to abuse than illegal drugs. And we know that's not true, and we know that young people aren't buying them in a piece of tinfoil from behind a gas station. In addition, recent studies found perceived prescription drug abuse as safer, less addictive, and less risky than using illegal drugs, and the drugs obtained from the medicine cabinet or the pharmacy were, in their perception, not as dangerous as those drugs that were obtained in other ways. A comprehensive approach is required to address the epidemic because prescription drug abuse problems pose unique challenges. It's important to balance prevention, education, and, something close to my heart, enforcement, with the need for legitimate access to the controlled substances was mentioned. Therefore, the administration has created an inclusive plan which brings together a variety of federal, state, local, and tribal groups to reduce prescription drug diversion and abuse. And while we have outlined our approach to this issue in the 2010 drug control strategy, the administration developed a separate plan focused specifically on prescription drugs. And next week, Director Lenhart and I, along with our federal partners, will release the administration's plan. Our prescription drug abuse prevention plan has 4 parts: education, prescription drug monitoring programs, proper medication disposal, and enforcement. And the first part of our response plan is education. Mandatory prescriber education as well as patient and parental education is essential. Second, each state should have a prescription drug monitoring program. These, known as PDMPs, are statewide databases that contain information on dispensed and controlled substances prescribed by healthcare providers. PDMPs should be interoperable and have the ability to share prescriber information. The third part of our plan calls for proper medication disposal. 70% of the people, as I said, reported getting their painkillers from a friend or relative, and we need to ensure that proper medication disposal programs are available. And in September, DEA held their National Take Back Day
Excuse me, Director,
and collected over 120 tons. Let me just close and say that I thank you for your attention, and I really appreciate the witnesses that will be coming after me, and my heart as a police chief lies out to those that have suffered.
Thank you. Administrator Lenhart, 5 minutes.
Chairman Bono Mack and Ranking Member Gonzalez, distinguished members of the subcommittee, thank you for the opportunity to discuss the growing epidemic of prescription drug abuse. and the critical role of the Drug Enforcement Administration in the enforcement of our nation's drug laws and regulations. The diversion and abuse of pharmaceutical-controlled substances is a significant and growing problem in the United States. Every leading indicator shows increases over relatively short periods of time in the use and abuse of these drugs. Pain clinics have emerged as a major source of controlled substances for non-legitimate medical purposes. DEA and other federal, state, and local law enforcement agencies have developed great working relationships and continuously coordinate efforts to combat this emerging threat. Federal administrative and criminal actions against a physician with controlled substance privileges is rare. However, such actions are warranted when a physician is issuing controlled substance prescriptions for an illegitimate purpose and operating outside the usual course of professional practice. And as administrator, I've made prescription drug abuse a top priority for the DEA. I'm especially alarmed that another contributing factor to the increase of prescription drug abuse is the availability of these drugs in the household. In many cases, prescription drugs remain in household medicine cabinets well after medication therapy has been completed, thus providing easy access for non-medical users for abuse, accidental ingestion, or illegal distribution for profit. The 2010 Partnership Attitude Tracking Study, PATS as we call it, noted that 51% of those surveyed believed that most teens get prescription drugs from their own family's medicine cabinets. DEA manages a robust regulatory program aimed at preventing and curbing diversion all the way from manufacturing levels to the dispensing of these medications to patients. And in working with Congress, DEA also obtained new authority last year to regulate the disposal of unused medications by ultimate users, thereby getting unused medications out of household medicine cabinets in a lawful and safe manner. DEA is working diligently to promulgate disposal regulations, and in the interim, DEA launched a nationwide take-back initiative in September of last year, resulting in the collection of 121 tons of unwanted or expired medications. And I'm pleased to announce that DEA is planning a second nationwide take-back initiative on April 30th, and we will continue to hold periodic take-back events until regulations are in place. DEA's obligation under the law and to the public is to ensure that pharmaceutical-controlled substances are prescribed and dispensed only for legitimate medical purposes in accordance with the Controlled Substances Act. By carrying out this obligation, DEA strives to minimize the diversion of pharmaceutical-controlled substances for abuse while ensuring that such medications are fully available to patients in accordance with the sound medical judgments of their physicians. In this matter, DEA is committed to balancing the need for diversion control and enforcement with the need for legitimate access to these drugs. DEA closely monitors the closed system through record-keeping requirements and mandatory reporting at all levels through the supply chain. And due to enhancements to our regulatory resources, controlled substance manufacturers, distributors, importers, exporters, and narcotic treatment programs are receiving more inspections and audits than ever before. A key component to our enhanced investigative resources are tactical diversion squads. These are unique groups that combine the skills of special agents, diversion investigators, intelligence analysts, and task force officers. TDS groups are dedicated solely towards investigating, disrupting, and dismantling those individuals or organizations involved in diversion schemes. And as of today, DEA has 37 operational TDS groups across the country, and we plan to add an additional 26 more over the next few years. And one example of the effectiveness of these tactical diversion squads is an Operation Pill Nation, which targeted rogue pain clinics in South Florida since February of last year and culminated in a series of major takedowns in February of this year. This led to 32 arrests, including 12 doctors and 5 pain clinic owners. DEA also immediately suspended 63 DEA registrations and issued orders to show cause on 6 more, which resulted in the surrender of 29 DEA registration numbers. And this caused a ripple effect throughout South Florida and resulted in 50 more DEA registrations being surrendered. And in total, we closed down 38 clinics. So DEA recognizes that it can't solve this problem alone. DEA is working closely with our federal, state, and local and private sectors as a part of the administration's comprehensive approach to combating prescription drug abuse. Many states have also adopted prescription drug monitoring programs, which are deemed to be a valuable tool in curbing diversion. In closing, I want to commend the courage of those who are testifying later this morning for putting names and faces of loved ones to this problem, and I want to express my heartfelt sympathy on behalf of the men and women of DEA for their loss. I'm keenly aware that many others, possibly here even today, have struggled with drug abuse by friends and family, and DEA joins in this fight. So thank you for the opportunity to appear here today.
I thank both of the panelists, and I will recognize myself for the first 5 minutes of questions, and I will begin by asking both of you to turn your attention to the charts on your right. Although the data is old, 2007, 2006, would you both, just yes or no, fair to assume that the trend continues to grow at an alarming rate, that the numbers today are far worse than they were in 2006 and 2007?
Yes.
Yes.
Thank you. And Administrator Leonhardt, you were specifically talking about Florida. Can you tell me how many doctors have been convicted or have had their DEA registration denied or revoked for overprescribing Schedule II prescription drugs? When Governor Scott points out that 98 of the 100 top prescribing doctors who prescribe these painkillers, that they are in Florida, doesn't that send off a huge warning flag?
Absolutely, Chairman. The actual numbers of doctors across the country that have been convicted, prosecuted, I can get you those numbers, but I can tell you you're absolutely correct in that 90 of the top 100 are in Florida. And Operation Pill Nation identified those top doctors.
Can you tell me what took so long?
Well, I can tell you that the trends have changed. The pill situation, the pill mill situation in Florida is a rarely new phenomena. We first targeted the internet, which if you go back 4 and 5 years ago, drugs that we were finding on the street and we were asking where they came from, they were coming from the internet, and it was unregulated, uncontrolled, and our first efforts were there. It's because of the Ryan-Haight Act that Congress gave us, and our actions going after those organizations and individuals dealing on the internet, that we were able to basically shut those rogue internet sites down. And then we saw the shift over the last couple of years in Florida. We spent the last year identifying the pill mills, and with a huge operation involving 12 of these tactical diversion squads over a period of a year, we're able to do those undercover buys that resulted in the takedown of Pill Nation. And we believe that that one consolidated takedown and actions over the past year will have a chilling effect on anyone attempting to open up a clinic or to continue in the same manner that they have continued over the past couple of years.
I see you have a chart on page 10 of your testimony that sort of reflects how effective the raids were. But I have a couple of questions for you just on basic math, and perhaps to both of you. Some people will say that last year we took back 272 tons of unwanted prescription drugs. Does that not mean we're over-prescribing 272 tons of these prescription drugs? And if that's the case, can you explain the quota system to me? It seems to me that there's simple math that you all are overlooking in the quota system. You both have the ability to determine how much of these painkillers are manufactured and pumped out into our society, but the quota is just simply based upon demand. I will turn to both of you, or most specifically, if you even look at Florida dispensed more than 41 million oxycodone pills. The second highest prescribing state dispensed 1 million pills. Large states like California have dispensed fewer than 400,000. What a disparity. Doesn't that clearly indicate that there are probably 40 million extra pills in the supply chain if you look at that mathematical equation?
Let me mention, I think, two things, and you bring up an excellent point on the quotas. So one thing is that the most recent data for all of 2010, for the first time in 8 years, shows that the aggregate production of opioid painkillers actually flattened. So instead of seeing that incredibly steep increase in abuse and the increase in manufacturing, we also saw a flattening. I think as we brought more attention to this, it's going to be coming down. The other concern would be on trying to restrict particular quotas for particular drugs. Will just turn to a different drug with a different problem, and that could lead to subsequent abuse. So I think quotas is one answer, and I think that it needs to be more robustly looked at. And I think those questions, along with our FDA partners, are important ones. But I also think that we're beginning to turn the corner on not only the aggregate amount of these painkillers that are produced, but also on the registrants who will have to have the mandatory education, the number of scripts they write.
And I agree with Director Kurlikowski. 121 tons of pills were collected at the take-back in September. There's a number of reasons, a number of things we need to look at. Overprescribing you brought up as an issue. I believe that's correct, and I believe that it requires more education for the practitioners who are prescribing, more education for parents, more education for young adults and teens who are turning in amazing numbers to prescription drugs as their drug of choice. And DEA is looking at the entire spectrum, and we are striking at every level of the distribution chain. And our problem is that with quotas, we have a job to make sure that there is enough medication produced and available for patients in need. And we need to balance that with making sure that people that are not patients that have a medical reason for these drugs don't get it. So it's that balancing act. And the problem with quotas is also that no matter what we do there, there will still be a legitimate group of people that need that medication. And so we try to get that target number.
Excuse me, my time has expired. I just wish I would hear you focus more on the people who are dying from these narcotics and painkillers than worrying about getting more out there. To me, the problem is 30,000 people a year are dying. And with that, I need to yield to Mr. Gonzalez for 5 minutes.
Thank you very much, Madam Chair. And again, thanks to the witnesses. And I understand that once a drug is manufactured, there's only certain ways it gets out there to the consumer, and that's going to be, it's on the shelves of the hospitals or the pharmacists, and then there's the prescription written by the doctor. And so I want to talk about databases. The first thing that occurs to me is that the most effective databases, and you have to have the assistance of all these individuals I just indicated, those are the points of origin. So like you're going to deal with any problem, you got to figure out if you go there first and try to control it best you can, then we can deal with the other things that take the responsibilities of parents and such, is to make sure that there's not the availability of those drugs in the medicine cabinet and so on. And then there's some other issues, but I'll discuss it with another panel, and it's going to go to what the chairwoman was talking about, the amount of drugs out there and what we can do, or prescription drugs, and what we can do. But until we really have, in my opinion, a truly robust and very effective widespread adoption of electronic medical records, health information technology, which is something that we've been attempting to do since I got here some years ago, I don't see how effective it's really going to be. Do you have any concerns about the abilities of all these different providers or points of origin to be able to access and to supply information in a manner that is timely and is going to be available, and of course electronically based.
You're absolutely right. I think it's a shame that when we have to have a chart that goes to the most recent data of 2006 or 2007, the President's drug control strategy devoted an entire chapter to the fact that timely, robust, critical information on whether it's the drug abuse warning network, which a number of people brought into the emergency rooms, whether it's the number of people we test in only 10 jails in the country for the drug problems of people coming in to the jail regardless of what they were arrested for. All of that information is so helpful, and frankly it's not timely and it's not as relevant as it should be, and therefore it makes it difficult, I'm sure, for you in the policy making area, and it certainly makes it very difficult for us in that area. So we have devoted this entire chapter to strengthening these kinds of systems, and I agree with you, electronic health records will be an important step forward.
Administrator Leonhardt.
Agree as well. And last June, we started the e-prescribing. I had signed for that and went into effect in June, and we're hoping that e-prescribing helps. I agree with you completely. And also, we do have 34 states that currently are using prescription drug monitoring program systems. And we see the value in doing that, how having a doctor or a pharmacist have the ability to look into a system and find out that someone has been doctor shopping or going from pharmacy to pharmacy has definitely assisted the states that have enacted those systems in preventing diversion.
And I know that we're always going to have this conflict. First of all, you have to respect confidentiality, the relationship for the patient with the doctor, the pharmacist, the professional, and so on. How do we balance all that? I mean, my fear is that people, one of the greatest impediments is people don't like the fact that this kind of information is going to be shared or is going to be made available. Now, I just believe that if it's made available to the health care professional, and in fact they act professionally, they're an incredible player or actor in this whole chain of how these drugs get out there. How do we balance the confidentiality aspects of it with, as we've said, a timely and robust database?
The PDMPs, I think the value in them is that they're designed by the states. So when the states enact them, they can put in the patient privacy and the confidentiality rules that they feel are best. They can also design them to as to who has access to them. Some allow, at certain points, access by law enforcement agencies. But frankly, the practice of medicine is governed by the states. The boards of pharmacy and the medical boards in each of those states having access to those, including routine reports that are generated from the PDMPs, actually put the information in the hands of the people that have the power to regulate medicine within each particular state.
On your next panel, you have Governor Beshear here, and I know Kentucky is a state that implemented PDMPs, was very concerned about the privacy issues, and their systems have been up and running and have not had problems in that area. And as we look at the other 33 states that have PDMPs up and running, they've addressed those privacy issues, and that has not been a deterrent. That has worked, and that's why 9 additional states have moved and have pending legislation in their states and are moving towards PDMPs. They've worked those issues out.
Thank you very much. I yield back.
Thank the gentleman. The chair recognizes Mr. Guthrie for 5 minutes.
Thank you, Madam Chairman. In the interest of time, I just want to ask one question and throw it out to both of you. I understand that prescription drugs are more accessible to people in the family. They get them from family members. You know, a parent may have OxyContin in their house where they wouldn't hopefully have one that you'd buy on this, typically would get on the street without prescriptions. But however, at what level is the prescription drug trade also in the organized crime, the drug cartels? And, you know, isn't just doctors overprescribing, or is there a whole network like you have in other type of drug issues?
I can tell you from our enforcement cases that, and we were surprised a few years back, we thought that they would there would be different organizations, they would act differently because they for the most part, are from the medical profession, they're pharmacists, and actually they are organized. We learned from Florida, these pill mill organizations are organized just like other organized crime and other crime groups selling coke and heroin.
Are they the same groups? Are the cartels organizing the pill mills, or is it different structure, I guess is my question.
I will say that they are, for the most part, different groups. We don't have a problem with prescription drugs coming from the Mexican drug cartels, for instance. This is one of those cases where the sources of supply are not in Colombia, are not in Mexico. The sources of supply are right here domestically.
I held a law enforcement roundtable last month in Buffalo, and one of the enforcement agents talked about a drug dealer in a particular section of the city in which heroin was being dealt, and then they had a subcomponent with a dealer dealing prescription drugs across the street.
Thank you, Madam Chair. I'll yield back in interest of time.
Would the gentleman just yield for one quick question?
Yeah, I'll yield to the
If the
chair.
two just briefly can explain how many people are dying from the illicit drugs any longer as compared to prescription drugs?
The prescription drug overdose death, that is driving the numbers that have spiked so significantly. They cause more deaths than both heroin and cocaine combined.
Thank you. And the gentleman yields back, so the chair recognizes Mr. Towns for 5 minutes.
Thank you very much. Let me begin by, you mentioned the fact that there was 34 states using the monitoring system. Have you been able to detect that those states are using the monitoring system, that the problem is not as severe in those areas, those states?
There are two things that I think will be helpful in this. One is that there's a recent evaluation done by the CDC through a contract, I believe, on prescription drug monitoring programs. They're relatively new. Some are used more and some are more robust than others. So the other issue will be how can they exchange information across state lines. All of the physicians that I've talked to and all of the people that I have been privileged to be engaged with that have had these programs find them not only to be helpful in identifying doctors who may be overprescribing, but patients who may be doctor shopping, and the doctors themselves talk about it as a patient safety tool.
Right.
I will say that we're looking at the trends. Florida is ground zero for prescription drug abuse, and there is
Do they monitor?
There is no current PDMP in place in Florida. As we took action over the last year in Operation Pill Nation, we are seeing these pill mills actually move, and they're starting to show up in Georgia. Georgia is a state without a prescription drug monitoring program. So we are concerned. We believe that states that do enact prescription drug monitoring programs, that's one of the first things they can do to combat the diversion in their states.
Right. Is there any program in place to work with families that might be taking a certain type of medication that might be very susceptible to illegal use in terms of a drug? If it's in the cabinet that it's locked a certain way, is there any kind of training program in place?
And I think when you hear later on from General Dean and the CADCA group, and we fund through our partner SAMHSA 740 drug-free communities. Part of those coalitions will be, part of their mission is to educate people about the dangers of the prescription drugs. There are now lock-in medicine cabinets that have been made available. There are pill containers that have locks. But we also think the important part is bringing this to the attention of people about what's inside. As the chairman mentioned, when you collect 121 tons of pills across the country in one 4-hour period, thanks to the leadership of DEA, that should be, in my old job, a clue that we have a problem.
we have been able to use the Take Back initiative, and will on April 30th do the same thing, to make it not only be a way to safely dispose of your expired and unused medication, but also to educate. And I attended one of the sites on September 25th for the Take Back, talked to a number of people who showed up turning in their prescription drugs, and to a T, they all said they didn't realize they had the medication stacking up in their medicine cabinet because they didn't want to flush it. They didn't want to throw it in the trash in case someone else could get it. They didn't know what to do with it. So the beauty of the Take Back has been a way to educate families about how to secure the medications, and overall having people realize that they don't need to hold on to that medication, and that they have elderly in the home that could be confused and take the wrong medication, and they have young adults in the home, and that's the number one source of supply for them.
Right. Thank you very much, Madam Chair. I yield back.
I thank the gentleman. The chair recognizes Mr. McKinley for 5 minutes.
Thank you, Madam Chairman. I'm just curious, in the Appalachian area of this country that has such a high prevalence of misuse of, why is that occurring? Is that because the medical community is abusing their prescription authority? Is it? I just going to get a sense, why is one area so highly using pain-killing medicine?
We just spent 4 days, 3 days in eastern Kentucky and 1 day in West Virginia, and spent a lot of time asking people and looking at that, including interviewing 14 women who were in the jail system as a result, 13 of them for prescription drugs. Could you speak up just a little bit, please? 13 of them as a result of prescription drugs. And what we found, particularly in Appalachia, was that one, people all know each other, and they can sometimes share those drugs that are in their medicine cabinet. Somebody has a back pain, and somebody else shares and says, here's something that I found helpful. The other problem came about as a result of people who had been prescribed a painkiller as a result of an injury. It could have been even a mining injury, and then ended up in a problem with that. It is a huge and significant problem, and we couldn't have made the inroads in understanding it better without the support of congressional staff that spent the 4 days with us there just less than 2 months ago.
And I would like to add that from our investigations and what we see, just as Kentucky, Ohio, Tennessee, we saw people that went down to Florida and would go to these pill mills. We saw that is a major source of supply for the pills that are on the streets in West Virginia. Junkets, people that, busloads of people that would go down to Florida, go to all these pill mills, get as many pills as they can, return to your area, and not only were some of them addicted themselves, but they'd have multiple.
I'm just struggling to understand why Appalachia. Why not Georgia? Why not Alabama? Why is it the Appalachian area is singled out for such high drug use, high painkiller use? I just wonder if they're not, if the prescribing physicians are, if it is the prescribing, maybe it is a pill mill, but what can we do? Because I struggle with it's just a region. I think it's a national issue.
It is.
I think neighbors in New York City know just their neighbors just as well as we do in West Virginia.
And you're absolutely right. As my travels across the country have clearly shown, this the prescription drug problem affects everyone, regardless of race, ethnicity, gender, or economic station in life. In particular, I think it gets more attention in Appalachia because of the abuse, and we heard a number of different reasons. I also think that it doesn't get quite the attention, perhaps in some places, because everyone that we met They're community-minded. They know each other, and there were no secrets. So if you had a friend or a relative as a result that was suffering as a result of prescription drug abuse, other folks knew about it. But I think that bringing attention to it, I think the work that the congressional staff has done in both places, West Virginia and Kentucky, will make a big difference.
Thank you. Yield back my time.
I thank the gentleman. The chair recognizes Mr. Harper for 5 minutes.
Thank you, Madam Chair. Director Kurlikowski, as you look at this issue, are PDMPs the only option out there for states to implement the sharing of this type of information?
Right now, for looking at doctors who may be overprescribing or patients who may be doctor shopping, the only systems available are those state-run, statewide PDMPs.
Well, are there any state PDMPs that stand out to you as a role model for other states to follow that you really are impressed with?
As the administrator also mentioned, I think we're both very impressed with what has happened in Kentucky.
Okay. With that, I yield back, Madam Chair.
I thank the gentleman, and the chair now recognizes Ms. Blackburn for 5 minutes.
Thank you so much, and I want to thank you all for being here. Very quickly, just a couple of things. Listening to you, reading your opening statements, accessibility is the big problem, it seems, and you're trying to get into that. Part of that, as I mentioned in my questions to you, looking at both the education components with individuals, physicians, and I think also personal responsibility and parental participation in this. Let me talk just a minute to you, with you. Ms. Leonhardt, you mentioned state monitoring systems, the problems in Florida, the pain clinics as being a problem. In Tennessee, I mean, we've been talking about prescription over prescribing by physicians since the days of Elvis. And you know, how are you all working with that? If you're doing state monitoring systems, is there a method that you're using to incentivize or grant to the states? You know, what is the your position on that, and how are you helping with the local and the state component of that? And if you want to submit this in writing, because I know we're tight on time, that's fine. But listening to you, it seems like if you're going to say, let's get to the crux of this, that getting to that linkage between your local and state agencies is part of the crux, and dealing with that overprescribing is another component.
We would be glad to submit to you after the hearing information on specifically what we're doing in Tennessee, and know that the law enforcement officials in Tennessee have worked with us, are partnered with us to do what we can to help Tennessee. And in many ways, they were kind of ahead of everyone, Tennessee and Kentucky, when it came to use of the Internet. We learned from Kentucky and Tennessee, for instance, that there were all these deliveries being made to people who were ordering substances over the Internet. Working with them, they helped us develop an Internet strategy. So
okay.
They are up on the problem. They have worked with us on the problem, but I will provide additional information on that.
That'll be great. And articulate what you're doing with the grants and the incentive in. Thank you. Yield back.
I thank the gentlelady. The chair recognizes Dr. Cassidy for 5 minutes.
I will also submit a few extra questions for the record, but in the interest of time, limit myself. Ms. Leonhardt, in your testimony, you refer to civil penalties levied against McKesson, CVS, Cardinal. So what is the role of these intermediaries, and what is the role of the manufacturer in terms of controlling this problem?
Well, manufacturers and distributors have a part to play. They have responsibilities, and what we do at DEA is we make sure that we make them aware of methods of diversion and ways that their companies, their organizations can do more to prevent diversion. In these cases, our investigations showed over and over again that these companies were not doing enough to prevent diversion. So we used our administrative authorities working with U.S. attorneys' offices around the country, we have brought more civil.
Well, let me ask you, just to be tight, I'm sure there's supply chain control. They can't. Are they required to report to you that Smith's Pharmacy in Dade County is ordering 500% more prescription drugs than you would think normally such a pharmacy would?
Yes, they have a responsibility to report diversion. They have a responsibility to report any suspicious order. And
define diversion.
I'm sorry?
Define diversion.
Diversion is where the controlled system for pharmaceuticals is not used, where pills and substances find their way outside of this closed distribution system. For instance, thefts, they're to report thefts and losses, but they're also to report pharmacies or rogue pharmacies that are ordering from them and ordering amounts that change or anything that raises a red flag that they are outside of their normal practices. We have investigated many cases have actually started from tips from the companies who have reported these suspicious orders.
Okay, thank you very much.
Those that are not doing it, then we hold them responsible.
I yield back.
I thank the gentleman, and the chair recognizes the gentleman from Washington, Mr. Inslee, for 5 minutes.
Thank you, Madam Chair. Thanks for letting me join you today. Chief, thanks for your leadership here. Just wonder if you can give us an update on the implementation of our drug take-back legislation. And it's very timely. I just left Lisa Jackson, the EPA administrator, and we were talking about endocrine disruptors in the water system that are changing the basic physiology of fish and frogs in rather disturbing ways. So we'd like to know how we're doing on this.
Earlier, the remarks were made about truly what a bipartisan issue this is, and to see the legislation passed in both houses and the president sign it, and then DEA to be so involved and in having public hearings already to look at how to restructure the way that pills can be safely disposed of and not causing an environmental damage has been really heartening. We have had great cooperation from EPA. DEA is certainly the lead, and I'm sure the administrator can mention that. But we're making good progress, and I think the other part is the interim steps that DEA has been taking through the drug take-backs. The next one will be April 30th for your calendar.
Thank you.
And I will add that we did hold a hearing a few months ago. Over 150 witnesses appeared. We took their information, their comments. We're working that, and we believe that we will actually have a proposed rule by the end of the summer. We'll publish that proposed rule. That will go out for a comment period, and we will then review all those comments and move forward with a final rule. But it's on track, and the comments have come in. We're reviewing them, and we want to especially thank you for participating in that.
So what would you describe as your biggest challenges to make this actually work? We have law enforcement is stressed. We've had reductions in the COPS program, and everybody has budgetary issues. If you were going to describe challenges that perhaps we could help you with in any way, what would you say they are?
Well, it's making sure that law enforcement has the tools to combat this at every level of the distribution chain, but it is also doing what we can. One of your panels has a number of the community coalitions and the community groups, the prevention groups. It's making sure that they are getting the message out and they're getting the support to be able to do that. It's working with doctors and prescribers and the medical community. It's what Director Kurlikowski and I will be announcing next week with this new prescription plan.
reauthorizing NASPR, removing the barrier that restricts the Veterans Administration from sharing prescription drug information. These are all things that Congress can actually do, requiring what will be proposed in mandatory prescriber education, those things.
Thank you very much.
Thank the gentleman. The chair recognizes Mr. Kinzinger for 5 minutes.
Thank you, Madam Chairwoman. Hi. In the interest of time, I'm going to keep this pretty short, and so feel free to do appropriately with your answers. For the Ms. Leonhardt, I've learned that certain companies are beginning to do a lot of reformulating of opiate drugs to make it more difficult for abusers to use and abuse the product. Do you believe reformulating has been effective in preventing the abuse of these drugs?
I appreciate the efforts in trying to reformulate so that they're not easily abused. However, I am concerned because we have seen with OxyContin that as soon as that was put out, we heard that there were, even on the internet, announcing ways that you could go around that. So we're very concerned, but we don't want to discourage industry from continuing to develop these drugs that can't be easily abused.
So have there been any, for either of you, any discussions about encouraging drug companies and generics to follow suit, or is this something that you personally feel is ineffective and not really worth pursuing?
I believe it is worth pursuing.
Okay, all right. That's pretty much all I have, unless you have something, sir. All right, I'll yield back.
I thank the gentleman very much, and I believe that concludes this panel. I want to thank our witnesses very, very much for your hard work on this issue, certainly the boots on the ground who are working this day in and day out and risking their lives to keep our society safe. We thank them all very much. Again, I appreciate your being here. The subcommittee will take about a 5-minute recess while we switch panels, so about 5 minutes. All right, the hearing will come back to order, please. On our second panel today, we have two very distinguished witnesses who are both deeply involved in the issues of prescription drug abuse and prescription drug diversion, which obviously go hand in hand. We are honored to have Florida Governor Rick Scott and Kentucky Governor Steve Beshear with us today for perspective on how this battle is faring in their states. Without objection, I would like to yield 1 minute each to Mr. Stearns and to Mr. Guthrie for welcoming remarks. Mr. Stearns, you're recognized for 1 minute.
Good morning, and thank you, Madam Chair. I am delighted to introduce my distinguished governor, Rick Scott, to testify today on drug abuse, prescription drug abuse. He's a U.S. Naval veteran and a lawyer from Southern Methodist University with his law degree. He started a business himself and met a payroll. He actually started Columbia Hospital Corporation and later became HCA. He's had experience with a small business that he and his wife and family and mother started to eventually become a large business. He was elected the governor in this November 2010. He's the 45th governor in our state. He lives in Naples, Florida, with his wife, Ann, 38 years, and they have two lovely daughters. And I'm certainly very proud to introduce Governor Rick Scott. Thank you, Madam Chair.
And thank you, Mr. Guthrie. You're recognized for 1 minute to introduce your witness.
Thank you, Madam Chairman, and my voice is kind of raspy because Kentucky's in full splendor. Its bloom is there, and it is a beautiful place to be, and invite people to come. And in a month, we'll have the world watching us, which we're excited about with the Kentucky Derby. But it's pleased to have Governor Beshear here, and I can speak for the whole delegation on our side that we work together on this issue. We want to work with our governor on this issue and make sure we move forward in Kentucky because it is a big issue. We have a great state, a beautiful state, but this is a problem that we're exposing here today and we're working to address. And Governor Beshear has been involved in Kentucky politics since being elected president of the his UK class, I believe, at the University of Kentucky. So just a few years ago, he got started in politics, but been in the General Assembly, Attorney General, Lieutenant Governor, and very active in civic life as an attorney in Lexington, and actually from West Kentucky, Dawson Springs, but practicing in the Lexington area. It's really pleased to have you here. Unfortunately, he got elected in 07. I got elected here in 08, so we only had a year that we worked together in Frankfort, but enjoyed working with you and pleased to have you here today. Thank you.
I thank my colleagues and also join them, along with the entire subcommittee, in welcoming the two of you today. You'll each be recognized for 5 minutes. There are timers on either side of your table that will reflect green. As they turn yellow, that means you're, surprise, surprise, getting close to needing to wrap it up. And when it hits red, if you could come to a conclusion of your remarks as quickly as you can, we would appreciate it very much. So, Governor Scott, you're recognized for 5 minutes. And, excuse me, Governor, there's a button on your microphone, and
how's that?
Much better, thank you.
All right. Chairman Bono, Mack, and members of the subcommittee, thank you for convening this important hearing on the perils of the illegal distribution of prescription drugs. I ask that my full testimony be submitted for the record. During my campaign and since becoming Florida's governor on January 4th, I have heard firsthand the heart-wrenching stories from family members and friends of those who have lost their livelihoods and tragically their loved ones to prescription drug addiction. So I've been working on solutions to this problem since being elected. And Chairman Bonomack, I know you have been personally touched by this epidemic. Florida, like much of the nation, has a long history in the fight against criminal drug distribution. The names of the drugs have changed, but the problem has remained. Today, one of the most common names in the fight is oxycodone. Consider some of the statistics from my state, and the scope of the problem becomes clear. 98 of the top 100 doctors dispensing oxycodone nationally are in Florida. 98 of the top 100. Concentrated around Miami, Tampa, and Orlando. 126 million pills of oxycodone are dispensed through Florida pharmacies. By far more oxycodone is dispensed in the state of Florida than in the rest of the nation combined. The targets for law enforcement have often been the street dealers and addicts, essentially the bottom level of the distribution chain. One tool that focuses on end users is a database focused on the patient level. This month in Florida, my Department of Health began implementation of such a database. While the database moves forward, I'm working on satisfying the privacy concerns of law-abiding citizens. In 2009, the Associated Press reported a massive privacy breach when hackers broke into Virginia's prescription drug database. They obtained more than 8.2 million patient records and a total of nearly 36 million prescriptions. In Florida, I continue working with my legislative partners to find solutions that protect patient privacy. More important than computer databases, though, is focusing on the resources of my administration on a law enforcement solution that starts at the top of the distribution chain instead of the bottom. Every day we see that pharmaceutical manufacturers and wholesalers turned a blind eye when massive amounts of narcotics stream into the same regions of Florida. Meanwhile, unscrupulous doctors work with storefront pill mills masquerading as legitimate health clinics. At each level, there is an opportunity for law enforcement to intervene and stop the illegal flow of drugs into our communities. In these first few months of my administration, I committed to provide a law enforcement solution, a statewide drug strike force. It ensures open channels of communication and multi-agency cooperation. The goal is clear: target the sources of these drugs before they hit the streets. It gives our local sheriffs and police chiefs a statewide coordinated effort that provides intelligence, analytical, and investigative support. As I speak to you today, local law enforcement strike teams are working to identify, investigate, and apprehend those in the medical and pharmaceutical distribution chains. I also directed all the state agencies in Florida to identify investigative resources, licensing and registration information, and analytical research that can be used by law enforcement. Florida Attorney General Pam Bondi is working with prosecutors across our state to ensure these criminals are prosecuted to the fullest extent of the law. I am grateful to all of these professionals for their commitment to this important work. Not only are these efforts focused on Florida, we are also coordinating with other states to shut down a national prescription drug pipeline that some have called the Oxy Express. We are aggressively working to shut down the illegal supply of prescription drugs from our state, both inside and outside of Florida. Since the beginning of my administration, there have been more than 50 arrests around the state, including a statewide sweep by law enforcement that raided 15 pill mills in 3 South Florida counties. Just the other day, I was disappointed to learn that a deputy sheriff in South Florida was the first drug trafficking arrest made since the initiation of the strike force. It is too early to go into the details on this and other cases, but I can tell you more investigations are underway and arrests will continue. With my partners in the Florida legislature, we will pass legislation in the next 3 weeks to prevent doctors from dispensing narcotics and require doctors divestiture of their pharmacies. Doctors who have forsaken their commitment to people's health in exchange for the quick buck of unethical and criminal dispensing must be put to an end. We'll also closely review the activities of wholesalers in Florida, and we'll put in place tough penalties for these manufacturers and distributors who fail to help us turn off the illegal supply chain. Let me conclude by telling you that this strategy, centered on a law enforcement solution and targeting the top of the distribution chain rather than the bottom, will make a difference. I applaud this committee for taking a serious look at the issue, and I want to ask you to also focus your energy at the sources of this problem. Together, if we hold the manufacturers, wholesalers, doctors, and pharmacies accountable, we can win this fight. Thank you very much.
Thank you, Governor Scott. Governor Beshear, you're recognized for 5 minutes.
Thank you, Madam Chairwoman, members of the committee. Thank you for allowing us to come here and discuss a national crisis that has been particularly destructive in Kentucky and in Appalachia in general, and that's the crisis of prescription drug abuse. Let me be frank. Our people in Kentucky are dying. An average of 82 Kentuckians each month fall victim to drug overdoses, the majority related to prescription drugs. That's more than 2 people a day. To put that in perspective, more people in Kentucky die from overdoses than from car wrecks. Greater still is the number of families decimated by the financial and social toll of this illicit drug use. In the words of our law enforcement officials, medical professionals, and coroners, what has long been a problem has become an epidemic. Our response in Kentucky has been aggressive. We've ramped up enforcement. We've expanded the availability of treatment. And we've implemented high-tech monitoring and record-keeping while working to share that information with other states. Our prescription drug monitoring program, called CASPR, was created more than a decade ago as a tool for both the medical and law enforcement communities and is now available electronically. Singled out by the White House in 2006 as a national model, CASPR is inclusive and easily accessible. Furthermore, In 2005, Kentucky became one of the first states to require a doctor's examination for the writing of scripts for powerful painkillers and to require internet pharmacies to be licensed in the state. 3 years later, Congress passed the Ryan-Haight Act. But these innovative efforts have not been enough, because as Kentucky has tightened its net, illicit drug users have found ready supplies of prescription drugs in other states with looser regulations, and we're not equipped to stop that. What is needed, clearly, is an aggressive nationwide response, one that recognizes that this country's prescription drug strategy is only as strong as the weakest link in the chain. I'm here to push three thoughts. One, I urge Congress to continue providing resources to the Harold Rogers Prescription Drug Monitoring Grant Program so that the work toward data sharing among states can continue. We've come too far with that program to stop now. 45 states have authorized prescription drug monitoring programs, and 34 are currently operating. At this point, I want to stop and salute the efforts of Congressman Hal Rogers of Kentucky. He has been a warrior on this issue of prescription drug abuse. Secondly, training must be mandated for those who prescribe controlled substances, especially Schedule II narcotics. These drugs and the risk of addiction and fatal overdoses must be more clearly understood by both doctors and patients. We can't leave this education simply to the pharmaceutical sales reps. And three, the Department of Justice must focus more attention and resources on Florida, especially South Florida, to stop the flow of prescription drugs. As Governor Scott and I have talked, it's a tremendous issue in his state, and we both acknowledge that. Some 60% of the prescription drugs sold and consumed illegally in Kentucky come from the loosely regulated pain clinics in Florida, with each trafficker bringing back on average more than $10,000 worth of drugs. In 2009, Kentucky State Police arrested more than 500 people from eastern Kentucky in its largest drug roundup ever, and every single suspect had ties to Florida. These pill traffickers are not amateurs. They're sophisticated. They're well-organized operations, and the fight against them must be well-organized as well. I appreciate the very aggressive efforts that Governor Scott is implementing in Florida to attack this problem. I appreciate the fact that I believe now they're going ahead to implement the monitoring system that they passed a year or so ago. And that, my friends, is good, but it is a start. As we both know, it is just a start. It's one piece of a much larger strategy that we have to apply. This is a national problem that demands national solutions. And the sooner we come together to recognize that, the greater our success will be. Thank you.
I thank both our governors and recognize myself for the first 5 minutes. I want to thank you both very much. I have encouragement that the two of you are sitting together. For those in the audience, to recognize this is a bipartisan panel. And if you were to have only read your written testimony, you thought there would have been some sparks flying, but seeing that there's definitely a meeting of the minds here and a recognition, first and foremost, that the problem exists. Governor Scott, congratulations on your recent election. But to you, I'm encouraged to hear you are going to move now forward with but I'm also hoping you are going to continue to reject the $1 million that Purdue Pharma offered you. Are you going to accept or reject that $1 million that Purdue Pharma offered you to fund the database?
We're not accepting it.
I thank you for that very much. Can you speak, though, a little bit more? You came in as a businessman and you saw first and foremost that the law was being broken and you wanted to come at it from law enforcement. Can you speak a little bit more about this approach? Because I would love to see people go to jail. I would love to see some of these bad actors in handcuffs being taken off. Can you speak to your efforts a little bit more thoroughly from the law enforcement side?
Well, here's what we can do before we pass. We're in the legislative session right now, and so we have a very aggressive bill that's going forward that will help law enforcement. But in the meantime, we have a strike force. Our Florida Department of Law Enforcement, we took monies out of that budget right now, and we took a lot of investigators from the Department of Health and other agencies, and provided help to each of our sheriffs and each of our police chiefs because they're just overwhelmed with this issue right now. We've got, at the state, we've got a lot more analytical and investigative research that we can do. So we're helping them deal with that. On top of that, we have a very aggressive Attorney General. Attorney General Bondi is very aggressive on this issue, and so we've done a good job with arrests so far. But it's not even like we talked about. There's 87% of the OxyContin that comes out of the country, prescribed out of the country, comes out of Florida right now. So the strike force is going to have a big impact. But I think a bigger impact is going to be the fact that the doctors will not be able to both prescribe and dispense. So that will stop that. They're not going to be able to own the pharmacies. We're going to have that. We're going to limit the number of prescriptions they can do a day. That will have a big impact. So it's just piece after piece after piece. And then, of course, as we know, they'll figure out something, then we'll have to continue to change. But I think all those things put together with all the data that we're helping our local law enforcement will have a big impact.
Governor, do you need any help changing laws up here in Washington that you have found? Are you changing state law?
You know, I think that probably the biggest thing we need to look at is regulating these manufacturers and what should these drugs be allowed to be used for. So I think the usage of it is. I mean, the fact that you can prescribe for these things. We're as Governor Beshear said, some of the things requiring the doctors to have to do a medical exam and all that. That already is being done, and it's never enough. There's always something else we're going to have to keep doing. But the first thing is, why are they even able to sell these things, and for what purpose? And shouldn't there be a much more limited purpose that these drugs can be used for?
Well, I look forward to working with you on these answers and moving forward, and I applaud that you're in the fight. And I also would like to mention Governor Kasich as a third governor who's become very involved. Governor Beshear, just a little bit of information. My parents fell in love and met before World War II at a little teeny tiny college called Berea, if you know Berea College in Kentucky. So it's a near and dear place to my heart. But you also came in here sort of loaded for bear, ready to set your sights only on Florida. But can you speak a little bit about what you hear the governor saying? You are encouraged about this willingness to cooperate?
Listen, this is not a partisan issue. This is a life and death issue, as we all know. And it requires us to work together. I don't know that there's going to ever be a total solution to this problem. It's always going to be with us. But we can sure make a significant impact if we work together and bring all the tools that we've got and cooperate together. You mentioned Governor Kasich in Ohio. We're working right now with Ohio trying to figure out how to share the information between our monitoring systems so that we can do an even better job than what we're doing.
I think, just in the sake of time, one of the biggest concerns, of course, is a privacy breach. And we're all very sensitive to that, and I think no more so any more than we are in healthcare. Can you speak specifically how you are protecting that data and consumers can feel confident that they have privacy that they need?
We've had the system now for 10 years, and we've got very strict privacy guidelines. It has had a successful track record. It has never been breached. It is a felony for folks to breach that system, and it's worked. The integrity of the system has held together. I don't know of any system, whether it's with the CIA or the State Department or the Defense Department or our monitoring system, that you can guarantee will never be breached, that will never find a way for somebody to hack into it. We obviously will continue to strengthen with the latest technology those security systems. But it's really a matter of weighing the issues here. There is a slight risk always, whether it's e-health records or whatever, that some breach can occur. But when you're looking at 82 Kentuckians a month dying, when you're looking at about 7 Floridians a day dying because of drug overdoses of legal prescription drugs, that's a pretty easy answer for me.
Well, I thank you very much. My time has expired. I recognize Ms. Blackburn for 5 minutes.
I want to stay right there with the privacy and the online database issue because we are the committee of jurisdiction with telecommunications and the internet. That's one of our subcommittees, and the privacy issue is one that we will do some work on this year. And Governor Beshear, you have had CASPER for 10 years, and I think it would be helpful to us as a committee as we consider both the larger privacy debate and as we look specific specifically at the prescription drug program, to have some guidance from you all, some suggestions of what you think we could focus on. And Governor Scott, let me just continue with the chairman's question to you. With these databases, what suggestions do you have, and where are you seeing the problems? Have you all come up with a way to guard against the breaches, and have you had any breach?
Well, we just started to implement ours. There was when I came into office, there was a lawsuit that prevented us from implementing it.
Okay.
So we're just now getting started, and so what we're doing is we're looking at what all the different states are doing with regard to privacy to come up with the best answer on dealing with that, because it's a big issue, and we have people worried about it.
All right. And Governor Beshear, did you say that you had or had not had a breach on your system?
No, we've never had a breach.
You have never had a breach
No.
in the 10 years.
Right.
So you feel like your firewalls and do you do an opt-in or opt-out on information and data share? Get back to me on that. I know time is sensitive.
I will. I'm not sure.
Okay, let's talk about education just a second, because this is something with the prior panel, as we had the DEA before us, that we looked on just a little bit. And I think that it is important for us to continue to move forward with education. I would like for you each to give me just a 1-minute response on what you are doing with public education, with personal responsibility education, with parental education. I know in Florida the pain clinics are a problem that was recently discussed, and then you have a little bit of history, Governor Beshear. So if you all would talk about the education component, that would be helpful. Governor Scott first.
Sure. Well, what we're doing is, first off, is making sure the public knows just through articles and things like that. First, just the public, make sure the public knows how big the problem is. I've done press conferences and things like that. I've brought it up through, we've had testimony in the legislature to talk about the issue. We've spent a lot of time this legislative session going through what the problems are. So that's the biggest thing we're doing right now.
Certainly the public education part of it, in terms of talking about it publicly, and it's talked about a lot publicly in Kentucky right now, and I'm glad of it, because at least it's exposing all of our citizens to this dreaded problem. We're also in our pharmacy schools, in our medical schools, we are pushing to make sure that our doctors really understand, the ones that are coming out, and the pharmacists understand what they're really doing, and that they don't get their information just from the drug reps. But they have the kind of information they need to handle these kinds of drugs very carefully and very effectively.
Do you think most Kentuckians realize you have the CASPER system in place?
I think there's probably a general knowledge we do, although it's probably not understood in terms of what it really does. But
Thank you.
We're looking at strengthening that system. Right now, doctors can voluntarily be in it or not be in it. I'm thinking of beginning discussions about making that a little stronger. Making that a little stronger. I think doctors ought to be in that program.
Okay, thank you both, and I yield back in the interest of time.
Thank the gentlelady. The chair recognizes Mr. Stearns for 5 minutes.
Thank you, Madam Chair. Governor Beshear, when you mentioned that more people are dying from overdose than automobile accidents, that's appalling. That is just a frightening statistic. Governor Scott, earlier we had a Florida delegation, Madam Chair, so I heard some of the testimony from the governor. And I guess the question that came up when we had the delegation meeting and off at your questions too, can pain clinics be subject to additional scrutiny before they're licensed to practice? Is that a place where we could start?
Yeah, we're doing that now. We're doing it through, we already have where they have to be licensed.
Right.
So we're doing that, but it's not perfect. It's not easy to get around, but you can get around it.
Right.
So yeah, that's absolutely one of the things that's in our bill. And but the big thing is, think about this: we know the manufacturer, we know the distributor, we know the doctors that are distributing it. We ought to be able to stop this if we just keep tracking it. Now, some people will change, and there'll be a new drug or something like that. But this is a legal distribution system that's doing it the wrong way. So we ought to be able, if we track it all the way and have criminal penalties and civil penalties for everybody that's doing the wrong thing, I think will have a dramatic impact in Florida for a period of time, and then something will change.
Governor Beshear, anything you want to add to that?
No, I think we need to be as aggressive as possible in all of these areas. We need to be aggressive in regulation of all of these folks and regulation of what the pharmaceutical companies can do in terms of who gets these drugs and how they are dispensed. We need to be very aggressive in the law enforcement area. And I think what Governor Scott is doing in Florida is showing that kind of commitment very quickly, and we've been doing that in Kentucky for some time also.
Intuitively, the relationship between the doctors and the pharmacies, is that anything that you as a governor, either one of you, can do in terms of educating or threatening or somehow trying to influence the relationship between the pharmacy and the doctor? Or is that sort of sacrosanct that there's nothing you can do?
We're doing it in our bill. We are the doctor that prescribes will not be able to own a pharmacy.
Oh, that's good.
So we're going to completely separate it, and then we'll have the data of we'll be able to track all the way through. So, but I think stopping the ownership will have a significant impact.
Is there any state that has in place some of the things you've already talked about, Governor?
I haven't seen anybody that restricted the ownership of pharmacies.
Okay. Yes.
One of the other things, and I'm not sure how his laws are set up, but I appoint the doctors to the Board of Medical Licensure and the pharmacists to the Pharmacy Regulatory Board, and I have made it a very clear point before I appoint anybody. I have them come in and we talk about these kinds of issues, and I get a commitment from these folks to really bore in and try to address these kinds of issues as much as possible. And I think that's just another tool that we have to attack this problem.
Now, is there anything that the federal government, either one of you, think we as legislators on the federal side, or perhaps direct the federal agencies in some way that could make your job easier so we can stop these drugs from coming down the pipeline? So any suggestion you have would be very, very helpful. Governor Scott?
Sure. I think the biggest thing is why, there ought to be restrictions on how these drugs can be used and what they can be prescribed for.
From the federal level?
Yeah.
Okay. From the FDA?
Right.
Okay.
Another area that I hope that you all will pay particular attention to are continued funding for the Hal Rogers Act that's on the books now. That will help the states to share information and develop the systems to share information, and that will be effective in this battle. The HIDA, the Burns JAG awards and grants that are made that help us fight this specific problem. I know that just as Governor Scott and I are fighting budget battles every day, you all are too, but some things are more important than others, and that's the way we all have to look at the way we balance our budgets. That's what I do, that's what he does, and I just ask you in that priority, put this priority up there.
Well, I want to thank you. My time's expired, but I think the fact that both of you governors took the time to come up here to talk about this serious problem, I think is accommodation to you and also for us having this hearing, Madam Chairman, because this shows that even though we're all trying to reduce spending up here, this is a priority, I think, that is very serious in this country, and we have ways to stop it. So thank you for your testimony.
Thank you, Mr. Stearns. Mr. Guthrie, you're recognized for 5 minutes.
Thank you very much, Madam Chairwoman. And also, your roots are from Muhlenberg County, or several generations back, I believe.
That's right.
Which is near where the governor's from, with a couple of counties over where the governor's from. So thanks so much. And I did mention the First Lady. She's from my area, so my home area, so I should have mentioned that in the introduction. So I appreciate what she's doing as well for our state. I was when we did Casper, I remember it coming forth, and I will tell you, there's not a legislative session that doesn't go on that, particularly the legislators from Appalachia, Robert Stivers, a good friend of mine, the Speaker, now Speaker Stumbo, have always pushed what can we do to improve monitoring, interdiction. I think at one time when burn grants weren't funded a couple of years ago, the state came in and helped with our multi-jurisdictional task force. So the Kentucky leadership is focused on this and trying to help solve this problem. But I think we tied in, if I remember, some of the participation into Medicaid, because it seems that the prescription drug problem is in areas that are heavily Medicaid as well. And I don't know if you, just the correlation between that, or if you've seen that as well, Governor.
Certainly, that, prescription drugs are allowed under the Medicaid program, obviously, and every state is involved in that program, and you're going to have some abuse within that program, and we're very aggressive in the Medicaid area of trying to weed that out, and at the same time, educate people. We're pushing in the Medicaid program the ability of our local health departments and those regional medical centers to educate our folks about the dangers of these narcotics. So many of these people that end up being addicts start out as legitimate drug users, that they need something for their pain or this or that, and they start out in a very legitimate way, and then they end up being addicted, and then they get into this cycle of buying the drugs illegally, and that just grows the problem.
And I know you weren't governor at the time, but when we passed Casper, I don't remember Florida being such a big issue for us 10 years ago. But did it just move to, because I-75, wonderful highway, we love I-75, but and people go to Florida and enjoy it and love it, but it also seems to be a pathway for the prescription drugs to come to Kentucky. And is that because we had Casper, so it stopped or helped curtail some of the problems we had, so it's just moved?
Sure. Before we had Casper, they would just stay in Kentucky and get these drugs illegally, and we haven't cut all of that out. I don't want to even imply that, but we made a significant impact in it by having this monitoring system among several tools that we have. And the fact is, no state's an island. Folks, if we stop them doing something in Kentucky, but they can do it across the state line, they'll go do it across the state line. And that's why it's so important for all of us, all across this country, to find ways to address this. It doesn't have to be uniform everywhere, but it has to be everywhere for this to really work.
Well, thanks. And I think I saw you on the news a couple of weeks ago, and I know Florida's in session, and I guess a bill had seemed to have failed in Florida that might have addressed this, but it sounds like Florida does have a bill moving forward in the legislature now. I don't know if it stalled or whatever, but I remember, Governor, I'm glad to see y'all together working on this because it's a problem for all of us. But what's going on in the Florida legislature to address the program, or the tracking, or the similar Casper deal?
Well, first off, the monitoring bill was passed last year. So there was a lawsuit that just got settled. That just got finished last Friday, I think.
Maybe that's what you were referring to.
Yeah, so that's finished. But we have a very good bill that looks like it's going to get out of both the House and the Senate, which everybody's signed off on, including the Attorney General, who's very focused on this. And it's if you prescribe the drug, you can't dispense it out of your office. You can't own part of a pharmacy. There's a restriction on the number of prescriptions you can do a day. We've got temper-resistant pads to write the prescriptions. We've got licensing of the pill mills. So we've got criminal penalties, civil penalties, going all the way up to the manufacturer. So, because we're going to try to do everything we can to stop it, because it's a big issue. When 98 of the top 100 doctors in the country prescribing oxycodone are in Florida.
So is Florida's laws different? Because I-75, you got to go through Tennessee and Georgia to get to Florida. Are y'all just so different? I know you're working on that, but is it so different now, the current status, than even Georgia or Tennessee? I mean, Kentuckians aren't going to Tennessee; they're going to Florida. So that's what's the difference, I guess. I guess
every state's been different.
And what's happened is that some of this is starting to move to Georgia, because Georgia doesn't have a monitoring system. Tennessee does, and that's, I think, initially what pushed it south. And Georgia may be the next place that we really have to push hard to get them to address this situation.
Well, thanks, Governor. Thanks for making the trip to Washington today. I appreciate it. Thanks. I have to go back now. I'm out of time.
I thank the gentleman. Mr. Harper, you're recognized for 5 minutes.
Thank you, Madam Chair, and welcome to each of you, and it's an honor to have you here, and thank you. This is a very important issue. We all have friends who have had their families devastated, primarily by young people who get those prescription drugs from their medicine cabinet at home. That's what seems to be a major problem. So how do we solve the underlying problem here is that no matter what regulations we put on, which will be very helpful, how do we convince these young people not to use the drugs, not to take them? Are you doing anything in conjunction with, say, success in, say, drug courts or in any faith-based programs? Governor Beshear, I'll ask you that first. So any coordination there?
Yes, we have drug courts. We have faith-based initiatives that all work in this area. Obviously, a part of it is education, and we're pushing that both in the public school system as well as through faith-based initiatives. The other end of it is treatment and rehabilitation. And we took a significant step recently in Kentucky by revising a major part of our correction system and our approach to corrections to put a lot of time and effort into treatment and rehabilitation so that we can stop recidivism and stop that revolving door to where folks just get out, you don't give them any help, you just turn them loose again, and within 30 days they're out trying to buy the drugs again and they're back in. And we brought the Pew Foundation into Kentucky and had a bipartisan effort of Republicans and Democrats, our House, our Senate, our Supreme Court, and the court system, as well as the governor, all got together. And we've made some major changes that I think on that end of the spectrum will address the recidivism rate.
Great. And Governor Scott, your state on dealing with, say, drug courts or faith-based initiatives to help in this effort, what is the story there?
Well, the big thing we're doing since I've been in office is educate the public to make sure everybody gets on board. First off, making sure we get this legislation passed. So it's very important to get that done. The strike force is very important. On top of that, just continue to educate the public. Our schools are educating the public. We also are, the individual I put in charge of Department of Corrections is very focused on this, and same thing as Kentucky, very focused on the number of people that get out of prison and go right back and have the same problem. So he is somebody that's very focused on that issue.
Well, obviously our goal is to make sure they never get into the court system in the first place, and how do we encourage folks this is not the route to go?
Well, one thing we've done is our juvenile justice is run by an individual that from Miami. She came up to work with me, and she's focused on a program that she's worked for 20 years in Miami that has had a dramatic impact in stopping sort of the first time you get stopped for something, you don't end up in prison just because it ends up being a cycle. So all the things she's done, starting with civil citations and starting with if you get stopped the first time, it's not just that issue. You might have an issue over food, shelter, family issues, things like that, and having a holistic approach to it to stop them from ultimately ending up in prison. So we're taking all the things that she's doing and spreading them across the state. On top of that, we have legislation that would allow us to do a civil citation program rather than immediately move it into a criminal program.
And how you secure the prescriptions at someone's home so that no one other than the intended patient gets it is a really tough thing to do. As far as I'm interested in what you said about your task force that you have in place. How are you going to measure the success or success of the mission of that task force? What are you anticipating or hoping for out of that?
Well, the numbers have to get better. We can't have 98 of the top 100 doctors, 126 million pills. Now, it's basically how do we stop just basically all this happening in our state? But it's going to be arrest. It's going to be the number of prescriptions that are done. In the end, it's prescriptions and death.
What about in working in conjunction with your state medical association? What input have they given either of you?
Well, in our case, they're very focused, and I'm doing something similar because I have the opportunity to appoint the members of the Board of Medicine. And so as I'm going through that process and talking to individuals about those positions, I've talked to them about how important this issue is and the fact that they've got to be engaged, and the Board of Medicine has to be engaged.
Governor Bashir?
Same thing here. You know, we're engaging the medical profession, the pharmacy profession, as well as their regulatory boards. And, you know, as I'm sure Governor Scott would point out, those boards, their first duty is to protect the public and not just protect themselves. And we see a little bit of that in every regulatory environment, whether that's lawyers, doctors, pharmacists, and I'm a lawyer, so I can say that about myself. But, you know, we've got to emphasize that their first duty is to the public and to protect the public, and it just comes down to appointing the right people.
Thank you each for being here. Madam Chair, I yield back.
Thank the gentleman. The chair recognizes Dr. Cassidy for 5 minutes.
Thank you for being here, gentlemen. My pain doctors really like the PDMPs because they feel like the pill mills give everybody else a bad name. Right. Now, that said, I gathered that from testimony that some of these PDMPs are robust and some of them are limited in ability. Now, Governor Scott, clearly you have legitimate concerns regarding the privacy. But as much as you can say, and I gather Kentucky has a rather robust program, where do you imagine yours will be on the spectrum? And I just mentioned that because at the previous meeting, Florida was described as ground zero for the promulgation, if you will, or the source, if you will, for these drugs across the nation. So just to ask you.
Well, it's clearly ground zero. So it's a significant issue, and the things that are Florida's problem is a problem for the whole country because we haven't stopped the abuse. So our database will be what we're doing is being one of the later states to do it. We'll be able to take all the benefits, take all the knowledge from the other states, which is what we're doing, both on to make sure we have the right information and also have the right privacy concerns that we can address. So we'll be doing both of those. But on top of that, we're gonna make sure we're tracking from the manufacturer to the wholesaler to the doctor, not just at the pharmacy after the fact, because after the fact is going to be a part of what we do. But I think the biggest part is going to be we're going to stop the distribution of it.
Yeah, I see that. Yeah, okay. Now, let me ask you, my pain doctors also tell me part of the problem is that someone may live on the Pearl River borders between Louisiana and Mississippi. And I think there's a Pearl, Mississippi and a Pearl, Louisiana. And they say they will live in one state and go to the other. And they will get as much as they can below the threshold here, and then they'll go back here. And they will do it as well on the other side. Now, clearly, that just may require a federal overlay. But as two fellows who obviously will be jealous and respective of states' prerogative, how do we keep folks from popping across state borders to maximize? You see where I'm going with that, Governor Bashir?
Well, first of all, both states need the monitoring program, and do both of them have that?
They both do, but but each is self-contained.
Right. And they need to be doing what we're doing with Ohio right now. We're sitting down and trying to work out how to share information, and we're going to do that. Governor Kasich and I will end up, we'll find a way to do that. And we're being helped by this Hal Rogers grant program. That's the money that's been provided to help states work to share information in these monitoring systems, and we need to continue that. We need that funding to continue doing this so that every state ultimately will be sharing across state lines. That's the only ultimate way that these programs will be as effective as possible.
So, so although you start off with Ohio, you share a border, you actually envision that eventually you may partner with Governor Scott, for example.
Yes.
And wherever there's a potential distribution, be able to go there.
Yes. We all need to partner eventually so that there is no place in this nation that people can go and be able to do what they're doing now as freely as they do it.
Now, Governor Scott, I have to admit, I'm just, I'm a gastroenterologist, which I tell people prepared me very well for Washington, D.C. So if what I'm about to ask you seems very simplistic, it may be. But it seems like if you know who those 98 docs are, all you need to do is have an undercover person walk in. I'm told these pill mills that you pay $250 or something for a visit. 5 minutes later, you walk out with a handful of prescriptions. It seems like you could go to each of these and put them out of business for inappropriate prescribing. Why not?
The difficulty is that the smart ones, what they're doing is it'll appear legitimate. They'll do the MRI. They'll do the history. They'll do all these things that so it's not as easy as just walking in and saying that you're doing something wrong. You've got to have. That's why we spent a lot of time on this legislation with the Attorney General and with the sheriffs and the police chiefs to make sure that what we're passing is something they're going to be able to convict with, because they'll do all everything I've been told. They'll do all the basic things to make sure it's very difficult to stop them.
Will the gentleman yield just 1 second?
I will.
I would think if you just let out the word that you're going to do sting operations, I mean, I would think that would create a pale over those physicians that might retard them from doing this. So I know, Governor Scott, it sounds difficult, but I think what the gentleman's saying is that the fact that these stings might or might not come would create some caution.
I think the difficulty is there's a lot of money in this.
Greed is.
There's a lot of money being made.
Thank the gentleman. We are fortunate to have the governor, as I understand, until 10:15, so we'd like to do a second round of questions until that point, if my colleagues are so inclined, and I will recognize myself for the first 5 minutes. And just point out a few things I think that are essential for this discussion. First and foremost, it was my understanding that OxyContin was originally approved for severe cancer, late stages of cancer, for severe pain, yet the #1 prescriber today of OxyContin to children 12 and over are dentists, and I think that should be pointed out. I'd also like to talk a little bit about the parental education words that keep coming up, and point out that we have 2 panels yet to speak who will show that parents of all walks of life are affected by this, and that it is impossible to detect this problem until it is too late. Governors, in your travels and your meetings with addicts and loved ones of addicts, first of all, would you be I contend that OxyContin is heroin. And would you take big umbrage with that? Would you say that's about right, what you're seeing in the...
You never know the definition, but I can tell you we ought to really restrict what it can be prescribed for.
I have a bill that just does that, and I'll be looking forward to working with you on that. You keep speaking also, Governor, about limiting all of these leftover pills in the medicine chest. And I keep wondering why we're prescribing, hundreds of tons of pills a year that go unused. Patients don't want them. Why are they getting out there? That's another question that I look forward to exploring with you. And Governor Scott, I want to applaud you on your decision to reject the $1 million from Purdue Pharma for your database. Just this recently, there was an article here that points out that the CDC authored a study where they linked these powerful painkillers to deaths, and then the University of Wisconsin School of Medicine released a study that disputed that and talked about liberalizing opioids, and lo and behold, financed by Purdue Pharma, and I'd like to submit this article for the record. And I think people need to start looking at the connection between these studies and these policies and the big money that you were just speaking about, Governor Scott. So, Governor Beshear, clarification again, if I might. You did say the number of fatalities in Kentucky from drug overdoses has now surpassed automobile accidents. Is that legal or illegal drugs again?
It's a combination, but the majority of it is legal drugs, abuse of legal drugs.
Thank you. And then, Governor Scott, as a businessman, when you look at the chart for the dramatic increase of opioid abuse, it's ironic that the trend line started screaming upwards shortly after OxyContin was approved. As a businessman, does that look kind of fishy to you, like it does to me?
Yes.
Thank you.
Oh, you should see if you look at my testimony, you see how many, 87% of it coming out of Florida too, and just a dramatic increase. It's just.
Thank you. And another point, and as somebody who has spoken publicly about my family's problem with this, or being involved with this, the disease of addiction, and it is a disease. And I'm happy that Congressman Harper brought up that side, that they shouldn't be necessarily in the courts, but we should treat it as a disease first and foremost. But as governors, when you meet the families that are suffering, aren't these just normal families, regular families? I can show you stacks and stacks, and I know you have the pictures too, of kids who are in their senior year of high school. One family member whose son died just a week before his graduation from high school, and he was an all-star athlete on the dean's list. Everything is right about these kids. Do you believe, like I do, that when these kids get access to these powerful painkillers, they don't stand a prayer and the ability to stay off of them?
This cuts across income brackets. It cuts across every bracket. This is a problem that everybody is having, and I don't know that there's anyone in my state or any other state anymore that doesn't know somebody, whether it's in their own family or a friend or another family, that's been affected by this.
Yeah, I mean, this a good friend of mine's 18-year-old just died 2 weeks ago, overdose. He found her, and it'd be horrible. But it impacts everybody.
Do you believe? Was your friend aware that his daughter was using?
He had found out, sent him to a program, but then what happens to a lot of people is that the kids turn 18, they don't have to be in a program, and so.
There's a mother who will speak to that on the next panel, to that very thing. Last thing, have either one of you ever met somebody who wanted to be addicted?
No, but I have a family member that's been addicted his whole life. Never beat it. Started at a young age and never beat it.
And it is a lifelong struggle. Again, I thank you two very much. I look forward to our continued working relationship, and again, I appreciate your courage and being here today. And the chair, I will now yield to Ms. Blackburn for 5 minutes.
Just to follow on, Governor Beshear, you mentioned you were thinking about putting your program as a mandate. And as I've said here, listening to you all respond to the questions, I'm thinking, it must be very difficult, and you may have some guidance for having a program that is an opt-in for your pharmacists and your physicians. And it seems as if those who are illegally prescribing or illegitimately prescribing, over-prescribing, would choose not to use the system. So I wonder if you would just explain a little bit about what has led you to that, and as Governor Scott is setting his program up, what would you advise him? Would you advise him for it to be a mandate from the get-go?
Well, I'm going to be sitting down with our medical licensure board and our medical association and the dentist and the pharmacist and talk about this. But so far, it's proven effective the way it's set up, in that the doctors that are using it can actually detect other doctors, even if they're not using it, that are over-prescribing and are abusing the system, as well as being able to detect those.
So you are using it as an accountability tool, even for those that are outside of the system?
Yes.
Okay, that's great. Now, how do you pay for your system, and what's the cost of it each year?
It's paid for by state funds.
Taxpayer dollars.
Taxpayer dollars, and
Okay.
I'm not sure, I can't tell you offhand.
If
what
you
it
would
costs,
submit
but
that.
It costs a fraction of what it costs to handle the problem the other way.
All right, and Governor Scott, you said you're not taking a grant that was offered to you, so how do you all intend to pay for your system?
We have funding from other individuals and companies that are putting the money up.
Are they
So
pharmaceutical companies or?
No, we've got 2 years of funding right now. Ours is, we're just starting to implement ours.
Correct.
No, it's not pharmaceutical companies.
So it's private funding?
Right.
So there is no taxpayer dollar involved?
No.
Okay, thank you. I yield back.
Chair recognizes Mr. Guthrie for 5 minutes.
Thank you, Madam Chairwoman. Again, I think that if I remember the problem, we were trying to define it in the legislature. It seemed to be Medicaid, where if you have private insurance and they limit how many prescriptions you can get over and over, and we had to address that with the Medicaid because it just seemed that's where a lot of prescriptions were coming. Not everyone. It cuts across all swaths of people, but the concentration of it was. And Mr. McKinley, you weren't here, Governor Beshear, earlier, but Mr. McKinley asked the question to the panel before, to the Drug and DEA, about why it's Appalachia seems to be in a bigger deal. And because in my area, because it's not only Appalachia using drugs in Kentucky, I can tell you that. In my area, though, it's methamphetamine. So every time we'd show up for Frankfurt for our legislative session, groups of us were trying to fight meth, and the other groups were fighting this, but it does seem the prescription drug part of it is concentrated in Appalachia, where in my area it's the illegal manufacture of meth. And do you, have y'all? I don't know the answer to that, and I thought it was a good question. Why he said earlier, I don't know if your task force, if y'all have looked at it that way. Why Appalachia seems to be more the prescription side? Maybe it's I-75 access to Florida, versus our area is not that way. I don't know.
Well, it's obviously a nationwide problem. There are, I think, concentrations of prescription drug abuse in some places. There's concentration of things like meth
in my area
and illegal drugs in other places. But it's obviously it blankets the United States, and it's getting worse, not better.
That's our point. When we come to Washington and talk about problems in our state, that we have to do that. But obviously, we have and you're the governor of my favorite state, and obviously a beautiful place. But we have to talk about these problems, and we have to get together and try to solve them. So, thank you very much for being here today.
Well, the first step is to recognize that we've got the problem.
I think the governor, Scott, wants to comment.
And one thing somebody just told me that there's no state taxpayer dollars, but we are going to get some dollars from the Hal Rogers federal grant. But there's no state taxpayer dollars.
Thank you for the clarification. I think
if you want my time, Madam Chairwoman, I can yield you my time back. Or?
Oh, thank you. I was taking it anyway.
Okay, go ahead. I was.
But thank you. I think the important point, too, is whether or not there was other pharmaceutical money involved, which is a question that we debate here on many things. But in this specific instance, I thought the Purdue Pharma, your decision was a good one. And I applaud both of you to wrap it up and to thank you for your time today and your spirit and the willingness to truly address this problem. We're not going to end it. We're not going to solve it entirely. But I do believe good, innocent people are suffering and crime. It's a very basic situation for me. The FDA approves and regulates, and the DEA is supposed to control. And with statistics like that, it shows that we're failing. And it's time to stop. Too many people are dying, and too many of our constituents, and more of my colleagues would have participated today. I know Congressman Vern Buchanan is very interested now. Congressmen from Massachusetts are very interested. This is not only Kentucky and Florida. It is nationwide. And as the panels go on, we'll focus on California and what is happening. So Florida, don't feel that it's all you, because it is throughout the country. But thank you, gentlemen, very much. Look forward to working with you. And at this point, the subcommittee will take a very brief recess to seat the third panel.
Thank you.
Okay, thanks. So as we get ours up, if you have any ideas on anything we're doing, just let me know.
I will, and I want to get
I must say.
All right, the subcommittee will return to order, please.
A recovering Oxycontin. So.
And I thank the staff for being so quick and switching the panels over.
But
on our third panel, as you can see, we've got 7 witnesses. As I introduce them all at once, first is Phil Bauer, surviving father of Mark Bauer. Phil serves on the Parent Advisory Board for the Partnership for a Drug-Free America. Our next witnesses are Kathy and Courtney Creighton, surviving mother and sister of Ryan Creighton. Kathy is also founder of Mothers Against Prescription Drug Abuse, and I'm blessed and lucky enough to call them my own constituents. Also testifying will be April Rivero, surviving mother of Joey Rivero and founder of the National Coalition Against Prescription Drug Abuse. Our next panelist is Dan Harrison, who overcame a prescription drug addiction to gain custody of his children. He is a drug court graduate and also a constituent of mine. And finally, we are pleased to have Dr. Carol Boyd and Dr. Amelia Aria, who are widely respected nationally for their insight into addiction. On a personal note, staff told me to say what I already said about how proud I am to have some constituents on this panel. So welcome to each and every one of you. I really appreciate your being here. If you can see the timer boxes down there, it's just like a traffic light, green, yellow, and red. You know what they mean. The total time you're allotted will be 5 minutes each. So we are now going to recognize Phil Bauer for 5 minutes. And, oh, yeah, a slight little problem. Would you please slide the microphone down to Mr. Bauer?
Is that good?
Yes, thank you.
Good morning, Chairman Bono Mack, Ranking Member Butterfield, and members of the subcommittee. My name is Phil Bauer, and I'm from York, Pennsylvania, and I'm here today speaking as a dad. If you were to ask any parent what their biggest fear in life is, their worst nightmare, most would tell you it'd be losing a child. We are living that nightmare, and it's worse than we ever could have imagined. Our youngest son, Mark, died from prescription drugs. His death was preventable and avoidable, and I believe the underlying cause was ignorance, my ignorance. Of all the things I worried about as a dad, abusive medicine wasn't among them. Unfortunately, there are many people who continue to underestimate the dangers of abusing prescription drugs, and as I know all too well, ignorance can be fatal. On June 4th, 2004, my wife Cookie and I, along with our oldest son Brian, attended the high school graduation of our youngest son Mark. As you know, there are many emotions that come with graduation, and it is a significant milestone and accomplishment in a young person's life. And the emotions are not just for the graduate, but for their families as well. Pride, happiness, relief, fear, sadness. It is a transition in life, and some refer to it as the beginning. The words I would use to describe our emotions at Mark's graduation are devastation, emptiness, and confusion. It marked the end of our son's life. I can remember so well sitting there and staring at an empty chair where Mark should have been sitting, with his cap and gown draped over the back of the chair and his yearbook and diploma laying on the seat. But Mark wasn't there. On May 28, 2004, on what would have been his last day of high school, just 1 week before graduation, Mark died. That morning, I responded to my wife's screams and went to see what was wrong, and she said she couldn't wake Mark up. I started CPR, and Cookie called 911. When the emergency personnel arrived, we followed the ambulance to the hospital, were escorted to the little room, and we heard the words that our son was dead. We went back to see him to try to say our goodbyes, and we cried on his lifeless body. And for Cookie and I, life as we knew it ended that day. In his room that morning, we found a clear plastic bag of loose pills. They weren't his, nor did they belong to anyone else in our family. There were 7 different types of pills in the bag, 119 pills in all. When the toxicology report came back 3 months later, it was consistent with what we found in the bag in his room. Mark died from a lethal mix of oxycodone, acetaminophen, morphine, and stimulants. Just to give you a little background of my family, when our sons were born, they became the focal point of our life. Their mom quit work and became a stay-at-home mom, and she has been a terrific mom. To me, being their dad has been the most rewarding and important part of my life. I was a diaper-changing, bath-giving, story-reading, full-service dad. I took them everywhere I went, diaper bag and all, and we were together constantly. Throughout the school years, our sons never came home to an empty house. Mark was quiet and an introvert. He didn't let many people into his life. You had to bring him into yours. When people took the time to know him, they found a wonderful, caring person. Never much for words, he had a terrific sense of humor and could make you laugh just by his expressions and mannerisms. He loved sports, especially basketball, and was an avid weightlifter from the time he was 11. In the latter stages of his life, Mark was 5'9", 175 pounds. He could dunk a basketball and bench press 400 pounds. Besides sports, he loved his family, friends, the Outer Banks of North Carolina, puppies, Star Wars, playing video games, any Leslie Nielsen movie, shopping with his mom, and making fun of his dad. One thing we will never know is why Mark chose to take these pills. We don't know if he was abusing prescription drugs to get high, or self-medicate, or to self-regulate. We also don't know if he had an addiction problem that went undetected, or if this was just an opportunity that presented itself. I know now that abuse of medicine can lead to the same dependence and addiction as that of illicit drugs. They can also be lethal on the first use, especially if mixed with other substances. Unfortunately, there are still many people who underestimate the dangers of abusing prescription drugs. They believe that abusing these medicines is safer than using illicit drugs, yet it's causing more deaths in our country than heroin and cocaine combined, and filling up our treatment centers. Based on the numbers from the CDC, on an average day in the United States, 31 people will die from prescription painkillers alone. From the motivation and inspiration that I draw from Mark's life and death, I have dedicated myself to do anything possible to raise awareness about prescription drug abuse. I have learned so much about this issue over the past several years and have had many mentors. My journey has included forging partnerships with organizations and agencies which share my passion and commitment to combat this issue. I am pleased and grateful to have the opportunity to now serve on the Parent Advisory Board of the Partnership at drugfree.org and to help promote and support their wonderful tools for parents. I have also had many opportunities to speak on this topic at national conferences, to law enforcement, to healthcare professionals, to community groups, and parent groups throughout Pennsylvania, and to high school students. I plan to continue these efforts as long as I am able. Abuse and misuse of prescription drugs is devastating too many families, causing crime and other social issues, filling our treatment centers, and killing too many of our children. There is no way to tell someone what it's like to lose a child. You either know what it's like or you don't, and I truly hope you don't. I am committed to do anything I can to help others avoid the devastation that Cookie and I live with every day.
Mr. Rivera, I'm sorry, if you could wrap up your minute over.
Today, I'd just like to offer my assistance to this subcommittee if there's anything at all I can do to support or promote your efforts to combat this public health crisis. Thank you.
Thank you very much. Ms. Creedon, you're recognized for 5 minutes.
Thank you. Good morning, everyone. Thank you, Chairman Bono Mack. I am so grateful to be here today, and I hope that my testimony provides valuable information that will help bring awareness about the epidemic of prescription drug abuse and diversion we currently face in our nation. My story is about the most severe consequences of abusing prescription drugs. I lost my son Ryan on September 4th, 2009 to an overdose of OxyContin. He was just 21 years old, and I agreed to come here today because I know there are thousands of families who are struggling with the pain of this situation just like I am. I sit here before you today on behalf of all of us and hope for some victory. And my daughter Courtney is here with me today, available to answer any questions after my testimony. So I just wanted to say that I fought relentlessly to save Ryan's life, but when addiction is present, it's like spinning your wheels to try to keep up with their compulsive behavior. I believe the science that says addiction is a disease, that addiction is a disease and it's not a moral failure. As my written testimony details, my son was easily able to obtain these medications from doctors. He didn't get his pills from my medicine cabinet. Once I realized he was getting medication through prescriptions and not on the streets, I thought I could stop it. He was an adult by this time, and HIPAA privacy laws made it difficult for me to communicate my concerns to the doctor about him abusing pills to his doctors, but that did not stop me. I was able to get my foot in the door more than once. However, my concerns were mostly ignored, and Ryan still continued to receive OxyContin many times for something as simple as a backache. In some cases, even when doctors stopped prescribing OxyContin, they still prescribed other narcotics that a person with a history of drug addiction should never have had. In the last 13 months of Ryan's life, I documented 7 pages of medical records for visits to doctors, urgent care, and emergency rooms. There were 6 near-death overdoses that always resulted in a 911 call and hospitalizations, once for 8 days in a lockdown facility. It was a life-or-death struggle for Ryan many times, and we lived in fear. I saw my son's addiction progress rapidly once he became addicted to OxyContin. I believe that was the result of the aggressive off-label marketing practices of Purdue Pharma. He was never a candidate to receive such a powerful addictive narcotic, and I feel he might be alive today if he had not discovered OxyContin. He made several attempts to get off the powerful opiate OxyContin, but did not make it longer than 30 to 90 days at a time. After my son's death, I had the opportunity to discuss all the careless mistakes made by the HMO that provided his care. I was told in that meeting that they were not aware of the dangers of OxyContin at the time my son was receiving it. They were told it was safer than other pain medications, including methadone, morphine, and fentanyl. That confirmed everything I had read regarding lawsuits and Purdue Pharma, and now my family was a victim of their misleading practices. In general, Kaiser Permanente, which was the HMO in our county, claims it was not aware of the abuse of prescription drugs taking place among our youth. I was quite surprised hearing that, because I thought that if I knew, surely they should have known. I then realized how important it was to figure out a way to bring awareness of the situation to the medical community as well. I believe that this lack of understanding contributed to my son's death. In addition to the fact that they continued prescribing him narcotics after they knew he was an addict, I feel that prescription education is so important. Ryan's addiction to OxyContin resulted in a felony conviction for altering a prescription at a pharmacy. He was obtaining prescriptions from many sources at the time. That could have been averted if a prescription monitoring program was in place. Some of those drugs ended up on the streets. Ryan basically became a drug dealer to support his addiction to OxyContin. It was unbearable to see what was happening to my son, at what lengths addiction will take a person to. So in closing, I would like to say I will not stop fighting for my son in his memory. As a result, I have joined with some others to create an organization to fight this epidemic. Our goal is to make a difference and to try to save lives by bringing awareness to as many people as possible. So I appeal to those of you in this room today from the bottom of my heart to help me make a difference. I thank you all so much for being here, and I would like to request that each of you reach out to other members of Congress, your colleagues, friends, and family to spread the word about this epidemic. And please be open-minded and learn all you can. Together we can make a difference. Thank you.
Thank you. And Courtney, I appreciate your being here to take questions at the end if we have them, but we will go to Ms. Rivero for your 5 minutes of questioning.
Testing, 1, 2, 3. Okay, Chairman Bono Mack and Ranking Member Butterfield and members of the subcommittee, thank you so much for having me here today. On December 18th, 2009, just a week before Christmas, my husband and I received the devastating and inconceivable news from a Tempe Police Department detective that our youngest son, Joey Rivero, had been found dead by friends in his apartment off campus near Arizona State University, where he attended college. Over the next few days, as we worked to get his body returned home to California where we live and funeral arrangements made so that we could bury him the day after Christmas, a story began to unfold that we were completely stunned by. We learned that Joey had been invited by a couple of students from ASU that he knew to travel with them on a 6-hour journey from Arizona to Rowland Heights, California, on December 9th, which was just 9 days earlier than his death, to visit a doctor who was well known for freely prescribing narcotic medications. All 3 students walked into this doctor's office together after the 6-hour drive, and they all walked out a short time later with prescriptions in hand. Joey's prescriptions, first time she had ever seen him, and after just a $75 payment to her, cash, and an x-ray that showed no problems in hand for him, was prescribed 90 30-milligram tablets of oxycodone, 90 350-milligram tablets of Soma, and 32-milligram tablets of Xanax. He and his friends were directed to a specific pharmacy that was at least 35 miles away from this doctor's office. They drove there together, and all of them had their prescriptions filled with absolutely no questions asked. We've since learned that both the doctor and the pharmacy had been under investigation for at least 2.5 years before Joey died. The DEA has since revoked her registration. The medical board has moved to revoke her license, and that's in progress. And criminal prosecution is expected for Joey's death, among several others, for this doctor. Joey had never been previously treated for any of the medications that were cited in his medical record by the doctor as the basis for the prescriptions that he received that day. And there's absolutely no indication that she counseled him on how dangerous these medications could be if they were misused or abused, especially with alcohol. So again, just 9 days after he saw her, he was dead. And that was after partying with friends in a college, a typical college setting. Wee hours into the morning, Joey went to sleep and he simply didn't wake up. The coroner's report indicated that he died from low levels of Xanax and moderate levels of oxycodone mixed with alcohol. His level of alcohol was .013. So he didn't have huge amounts in his system. The medical examiner indicated that none of the individual ingredients were lethal, but all of them in combination were. So it was the polymix that was a problem. Joey was due home for winter break the day after he died, and the Christmas we expected to share with him never happened. Instead, we somehow managed to get through the most awful week of our lives. Stunned, shocked, and grieving, we picked out a gravesite, coffins, and clothes for Joey to be buried in. I had to write an obituary for a young man who had not had time to develop the lifetime achievements that he should have been able to cite. Through it all, we struggled to understand how this could have happened to him, how our perfectly normal family could have been dealt such a blow. There really are no words that can adequately describe what my husband and Joey's brother and all of the other members of our family have experienced with his death. He was my husband's only biological child, and his brother's now left with no sibling. And as his mother, I truly feel as though a part of me is gone and just ripped away from me forever. Our lives were irrevocably changed that night that he died. Joey wasn't a troubled man, a young man. I want you to know that. He was a senior at ASU, just 5 months away from graduating. He was a gifted athlete and a good student, even making the Dean's List at ASU the fall of 2008. He worked every summer. He made money. He spent it wisely. He had a loving and caring relationship with all of his family members. He had tons of friends all over the country, and over 200 of them appeared at his funeral to support us and to honor Joey. His life has affected them also dramatically. Unfortunately, tragedy struck once again 9 months to the day after my son's death, when one of his 2 college roommates shot and killed himself in front of his girlfriend after a heavy night of drinking and prescription drug abuse. This problem has just continued to manifest itself in that college environment. There have been 6 young men that have died over the course of the last year at that university alone. And in addition to that, as we've heard today, in Florida we lose 7 people a day, and over 32,000 people a year die from adverse reactions to medication. So something simply has to be done with this epidemic. It's extremely important to me that I do whatever I can to make a difference. We've formed our National Coalition Against Prescription Drug Abuse, and I speak everywhere I possibly can to parents, students, educators, and community leaders about this problem. One thing that I wanted to point out that hasn't been mentioned today, I have a whole list of recommendations. Many of them have been talked about today. I think the one that I really want to make sure is mentioned is that the pharmaceutical industry has been allowed over time to expand its influence over virtually every facet of American life, using its near unlimited financial resources to influence the FDA and other governmental agencies, our educational research facilities, our legislators, unfortunately, and most alarmingly, our physicians and other medical providers. They're influencing medical research, drug trials, and are compensating doctors to prescribe medications they want to become their next blockbuster drug. The spider web of influence needs to be dismantled. Thank you very much for having me here today.
Thank you, Ms. Rivero. Mr. Harrison, you're recognized for the 5 minutes, and please do try to keep an eye on that red light for me.
Yes, thank you, Chairwoman Bono Mack, Ranking Member Butterfield, and distinguished members of Commerce, Manufacturing and Trade Subcommittee for giving me this opportunity to speak before you today. I'm very honored to be here. My name is Dan Harrison. I'm a tribal member of the Muskogee Creek Nation of Oklahoma. I currently reside in Palm Springs, California, where I've been for the past 20 years. I have worked as a structural iron worker and achieved apprenticeship status. In September of 1995, I took a fall on the construction site. My fall not only resulted in a severe back injury, but led to a life of addiction. After injuring my back, I went on to disability for a couple of months, then finally went to an orthopedic surgeon, and I was told that I would need to have a surgery which could result in never achieving 100% mobility. I chose not to have the surgery and developed my own solution of physical therapy and pain medication. After 90 days, I stopped going to physical therapy and started drinking to intensify the effects of the pain medication. As the days went on, my drinking and opiate use increased, and my life started spiraling out of control. During this time, my wife and I separated, and I shared custody of our 2 daughters. In 1999, I remarried, and soon after, my 3rd child was born. This all occurred while I had severe dependence on opiates and alcohol. The drugs are what got me through the day. I never had to go back to the doctor's office after my initial injury so often. I developed such a strong relationship with the doctors that I had need only to call, and they would refill my prescription with no questions asked. I would go into local emergency rooms where the doctor would see me and wave me back for regular pain injections. I rarely had to resort to the streets for my medications. Depending on what type of narcotic I wanted and the method of administrating it, the drug resulted in which doctor I would call. In October of 2008, I decided I wanted to fight for full custody of my daughters. I felt that their mother was not caring for them the way that I felt they should be cared for. I decided to call Child Protective Services. After the investigation, they were removed from the mother's care. When the caseworker showed up unannounced at my home, I had several cabinets full of prescription medication. When I was confronted, I admitted to the recent use of Oxycontin, Vicodin, morphine, Lortab, Demerol, Dilaudid, and marijuana. After hearing myself admitted to the amount of drugs in my system and seeing the caseworker's response, I knew it was time to make a change. The only way I would ever get custody of my daughters was to get help. I entered the Family Preservation Court, otherwise known as Family Dependency Treatment Court. The Family Preservation Court applies the drug court model to child welfare cases that involve an allegation of child abuse or neglect related to substance abuse. The Family Preservation Court seeks to do what is in the best interest of the family by providing a safe and secure environment for the child while intensively intervening in the treatment of the parents, substance abuse, and other comorbidity issues. This approach also results in better collaboration between agencies and better compliance with treatment and other family court orders necessary to improve child protective case outcomes. Since graduating from the program, I have learned that there are 2,500 drug courts, including over 300 family dependency treatment courts in the United States. I'm humbled to know that now over 120,000 addicted people a year have the opportunity for treatment and restoration in these courts, and I hope that someday they are available to everyone who needs them. These courts have been proven to cut up to 45% of the crime rate, and produce up to $27 for every dollar invested. When I first entered the Family Preservation Court, I had not accepted my problem, and I was a little uneasy with myself for calling the CPS since the investigation turned on me. However, after my intake and sharing my history with the Family Preservation Counselor, I realized how bad things had gotten. Through the Family Preservation Court, upon the counseling and obtained guidance in educating my daughters about the addiction, I participated in parenting courses that taught me to effectively communicate with my children, how to create healthy boundaries. I was given support by my counselors and peers throughout my struggles with the reunification process. In 2010, I graduated from the Family Preservation Court. Today, I'm thankful that I called the CPS. Without their intervention, I would not be here today. Family Preservation Court has helped me realize that I needed help. I needed to get help for myself as well as my family. As a result of completing the program and completing other family parenting courses, I've vowed to work diligently with the program and CPS side by side to work to do some outreach work for the ones that are still suffering from prescription drug use in the local community as well as the tribal community in Southern California. I thank you for allowing me to come here and share just a little bit of my story. I realize today that I am a miracle that's set here because of my addiction and going through the process of my recovery. I realize how serious this epidemic is today. So thank you for inviting me here today to share my story. I'm very humbled by that. Thank you very much.
Thank you, Mr. Harrison. Dr. Boyd, you're recognized.
Thank you. Thank you for inviting me today. My comments draw on my research that's primarily funded by the NIH, among other sources. I've been studying this for the past 10 years. You've heard today that over the past 15 years, prescriptions for controlled medications have nearly doubled for adolescents and young adults. And these come from office visits, from ED visits, and significantly in this age group, from oral surgeons. And once the youth have the pills in their hand, they are at risk for diverting them. Approximately 10% of adolescents in a given year have diverted their pain medicines. 15% have diverted their stimulant medications. And like other researchers, we find that girls are more likely to divert by loaning and giving, and boys are more likely to divert by selling. There are also socioeconomic differences among these adolescents. Approximately 10% of all youth will divert their pills to their parents. Overall, 1 in 6 of adolescents with legal prescriptions will be approached in a given year to divert their medicines, and in some cases they will be asked to rent them. It is usually stimulants in this age group that are being diverted, but not exclusively. We have found that the more elite the school and the more elite the university, the more likely diversion is to occur, and again, it is often stimulants. This is not to say that opioids are not the problem either, though. Motives to divert, as well as to use diverted medications, are wide-ranging, and it should not be assumed that the motives always involve getting high. Indeed, motives are one of the reasons that this problem is so difficult to prevent. So I'd like to share with you 3 cases from our own studies, and they highlight what we found in our research. The first one is a 16-year-old teen. She's an honor student. She was going to homecoming. She had a new boyfriend. 4 hours before the event, she got a migraine headache. And she went to her mother, and her mother gave her one of her own hydrocodone tablets that she had left over from her hysterectomy. The teen took it, went to the event. When I interviewed her, she had had a great time, and she did not use hydrocodone again. The second case, a 15-year-old boy attends an elite high school and is having trouble getting his work done. His best friend has a prescription for Adderall and keeps it on the dresser in the house. And when his friend leaves the house, his friend takes the Adderall. When I talked to this young man, he said, well, you know, everyone in my school is using it. Everyone uses it to study. And then in the third case, this is a high school girl. She did have a history of alcohol abuse, who was given an oxycodone tablet from her girlfriend who had also gotten it for oral surgery. She wanted to experiment to see what it does. Now, this is a girl that also was abusing alcohol. She crushed and snorted the pill, and she found herself continuing to use what she called oxy when she wanted to party with her friend. Now, these cases represent what we have found in our research. First, diversion in this age group usually occurs among family and friends. 2, there are gender differences. 3, it usually involves one primary prescription, and it is often from oral surgeons and dentists. 4, the diverted medicine is often started for the purpose of self-treatment, so that you see youth thinking that they're going to use it for a headache or that they're going to study harder. But then once they start using it, they have it available to them. And finally, the controlled medications are readily available. They are advertised on television. We do advertise controlled medications on television with direct-to-consumer marketing. And they are not stored properly, nor are they disposed of. And I hear this time and time again from youth. The adolescent girl that was in my case 3 is the one that is at the absolute highest risk. She is a polydrug user, and she's using for recreational purposes. It is these sensation-seeking youth that our data find have the biggest problems and are at the greatest risk for drug addiction and death. Most social scientists end their talk by saying we need more data, and I'm going to tell you that as well. It is difficult to understand why a country such as ours has data from 2006. We need regional data. We need national data that is more nuanced, that tells us the complexity of the problem. But policymakers can also do something. The FDA has recently stipulated that medicine bottles need to carry the schedule on them. I called my son, who has a prescription for Adderall, before I came here today, and I said, "Did you pick up your prescription bottle?" And he said, "Yeah." And I said, "Well, what about the labeling? Did it look different?" No, he said, "It doesn't look any different." I said, "Come on, Joseph, look, see if it looks different." Oh, yeah, maybe. This isn't enough. These bottles, I have a prescription that tells me on the back not to use it with grapefruit juice. These prescription bottles need to be clearly labeled that it is unlawful to share the medication, that that they need to be stored correctly, and how they need to be disposed of. The solution to this problem lies in the recognition that it is far more complex than actually street drug use. And it's going to require cooperation with pharmaceutical companies, healthcare providers, families, young people, and policymakers. Thank you.
Thank you. Dr. Arya?
Chairman Bono Mack, Ranking Member Butterfield, members of the subcommittee, thank you for this opportunity to testify on the problem as it manifests among our nation's youth. I come at this issue as a researcher at the University of Maryland and the Treatment Research Institute in Philadelphia, but I'm a mom too. Since 2003, with my dedicated staff, I have led the College Life Study, a NIDA-funded study of more than 1,200 college students. Consider our findings regarding non-medical use. By the 4th year of college, 13% used a tranquilizer, 23% an analgesic, and 30% a stimulant without a prescription. We found that more than 1/3 with prescriptions shared or sold their medications, usually to a friend. Most commonly diverted are stimulants, such as Adderall, with a 62% diversion rate. And individuals who divert prescription drugs are typically non-medical users themselves. Let me sharpen the focus on this particular aspect of the problem, stimulants. They are widely available and attractive to students with high task demands, especially those experiencing academic difficulties. There is a popular assumption that taking stimulants non-medically confers an academic edge and is therefore beneficial. Headlines referencing smart drugs perpetuate the notion that non-medical prescription stimulant use increases academic performance. Scientific evidence tells us quite the opposite. It is not the academically successful students who use them, but the unsuccessful ones. We know that non-medical users compared to non-users are more likely to be dependent on alcohol and/or marijuana, skip class more frequently, and spend less time studying. And digging even deeper, we see that these academic problems are related to heavy drinking and marijuana use. What the research shows is that non-medical prescription stimulant use is an unsuccessful shortcut, an attempt to compensate for declining academic performance, and is a red flag for an underlying alcohol or drug problem. What can policymakers do about prescription drug abuse? The single best thing is to tighten the chain of custody that ultimately governs supply. For example, put in place better prescription monitoring programs, reform physician dosing practices, and create timely surveillance databases. National data are often old, and state-level data are not even available to researchers. The prescription drug problem has complicated the landscape of existing drug threats. It does not occur in isolation. Individuals who use prescription drugs non-medically are very likely to be heavy drinkers and/or illicit drug users. Therefore, in addition to dealing with this devastating symptom, we must redouble our efforts to develop innovative solutions to the root issue. That is the larger public health problem of drug use and addiction in the United States. What specific strategies should be proposed? Today, I recommend two things regarding prevention and intervention. One, modernize the nation's infrastructure for early detection. We can identify those who are at highest risk for drug problems, just like knowing who's at risk for other chronic health conditions. With an approach that involves standardized assessments, early intervention, and promotes teamwork between parents, physicians, and educators, we can put these young people back on track to fulfill their potential. To this end, NIH research has yielded valuable information about risk and resiliency, the interplay between genetics and the environment, and the natural history and course of addiction. Effective solutions to this enormous public health threat will require continued funding for NIH research. Number two, connect the dots between drug use and academic problems. This link cannot be ignored any longer. Making this connection loud and clear will get the attention of parents who want who want more than anything else to see their child succeed. Tacit approval by parents and students of underage drinking as normative and college as a 5-year party, especially when there are stimulant drugs as a last resort, is completely misguided but regrettably an all too common notion. Similarly, we must engage the leaders of our education system who are concerned about the high school dropout crisis and less than optimal college graduation rates. They must recognize the very real and contributory role of drug use to poor academic achievement. Sustaining our economy and navigating future challenges will require a clear mind and a sharp focus, which is inconsistent with underage drinking, excessive drinking, illicit and non-medical prescription drug use. Again, thank you for shedding light on this continuing public health problem and allowing me to contribute to the discussion on solutions.
Thank you. I thank all of the panelists very much, certainly the parents who are hurting. I thank you for your advocacy and your passion turned towards helping others. Dr. Boyd, the statistics I'm looking at completely dispute what you're saying. As I look at the Drug Abuse Warning Network statistics as published by SAMHSA, you said that stimulants are the problem, and you also say that opiate addiction has doubled. Is that, did I not hear that correctly?
No, that that prescriptions for controlled medications for young adults and adolescents, I think this is what you're referring to, has nearly doubled since 1994 to 2007. This is Fortuna's work, what's published in Pediatrics.
Now, this is not specific to adolescents, but when I look at these numbers for the increase of emergency department visits, now old data, but from 2004 to 2009, stimulants altogether, again, not specific to adolescents, but I would think the trend would be similar. 20,490 admitted to ERs in the year 2004. That increased to 25,889 by 2009, 5,000 person increase over those years. While oxycodone and combinations and thereof, 41,701 in 2004. One would think to act that the crisis is similar, that would double, but in fact it actually increased to 148,449. So you spent the bulk of your time talking about stimulants, but I'm not aware particularly, I'm sorry I don't have the data here, but would you say that the trend line for stimulants and fatalities for stimulants is similar to opiates and OxyContin?
No, I wouldn't. And actually, I did not intend to give the impression that I was mostly talking about stimulants, actually. When I was speaking of the controlled medications, I was speaking of the 4 schedules, and that, for instance, 10% of my in our sample had diverted their pain medication, where 15% had diverted stimulants. Remember, this is 12
let me jump to Ms. Creedon here, because, and even to Mr. Harrison, and thank God that you are here as a recovering addict. I'm so proud of your courage. Thank you for being here. And to Kathy Creedon, I mean, this is the scientific community, and you guys have lived it in the real world. Is this just diversion from the simple places they see? Kathy, Ms. Creedon, in your testimony, I wish you would go on a little bit more. You talk a great deal, and you didn't talk, you mentioned you have 7 pages of documentation that show the runaround and what they call the smurfing of the great lengths your son went to that had nothing to do with your medicine cabinet. Would you be willing to submit your 7 pages and 72 entries of medical history? Would you be able to submit those things for the record, congressional record, so we can take a look at all of that? But are you hearing what you witnessed on the real street side of what's really happening out there in California and the homes? Is it paralleling what the scientists are saying here?
That the drugs are coming from parents' medicine cabinets? Is
Or,
the question?
Perhaps I'm a little on edge. It almost seems that you act as if a 16-year-old honor student was given a hydrocodone, Dr. Boyd, and the teen went to the event. She had a great time, but she never used hydrocodone again. So it seems to downplay, and you're acting as if, the diversion is, well, mom gave it to a 16-year-old. She had a great time at a party. And I just take issue with that, because this is a mother who never, ever dreamt of doing such a thing.
Absolutely. But speaking as a social scientist, this is also happening, so that when we look at the data on diversion, we see all kinds of diversion. And we see that also parents are role modeling sharing medications that are controlled. The mother shouldn't have had extra hydrocodone available.
But Ms. Creedon, you had no hydrocodone. You had no oxycodone. Can you speak a little bit about the great lengths your son went to that had nothing to do with this? You are like Ms. Rivero and Mr. Bauer, a loving parent doing your best to raise a teenager, or young Ms. Creedon.
Yeah, if I can speak to this. I mean, I think the reputation certainly is out there that, and we've heard a lot of that today, that I guess there were some statistics floating around that most people get these drugs from their parents' medicine cabinets, but in our case, that did not happen. We never had any of these drugs in our house. My mother never condoned using drugs. I mean, when we do submit these records, I mean, Ryan went out of his way to visit every doctor imaginable and finagle every aspect of the system to make this work, and surprisingly, it wasn't that difficult. And so it's kind of hard for us to sit here and hear people talk about, I guess, parent responsibility, when really I think the bigger issue is responsibility, or rather irresponsibility, of the medical community, and that none of these drugs came from our home. All of these drugs that Ryan used and the drugs he died from were obtained legally from licensed physicians.
Thank you. I have to yield now to the ranking member, Mr. Butterfield, but we will have a second and third round of questioning. So, Mr. Butterfield, recognized.
Let me thank the chairman for convening this very important hearing today. Those of us on this side of the aisle are also acutely aware of the pervasive problem that we have with prescription drug abuse, and so the hearing today is very timely, and I want to thank the witnesses for their testimony. In my prior life, I was a trial judge in North Carolina. I did that for 15 years, and so I have seen and heard heart-wrenching stories for many years over my career, and I want to extend my personal condolences and concern to those families who have been directly affected. I want to just ask one or two questions. I won't belabor this unnecessarily, but let me start this way. Prescription drug abusers do so for a variety of reasons, and I think we recognize that today. There are many reasons that contribute to this problem. Some people use them recreationally, some seeking their euphoric, relaxing, or energizing effects. Other people with or without a prescription use them inappropriately, seeking to alleviate minor pain and treat a perceived illness or even to manage stress. Still other people use prescription drugs for their intended purpose, but obtain them without a prescription. To Dr. Rear and Dr. Boyd, do we have data in percentage terms which demonstrate either for the population as a whole or for high school or college age individuals why prescription drugs are being used? In other words, for what reasons by percentage do young people decide to take prescription drugs without a prescription?
Sure.
Yes.
The percentages vary by class of prescription drug. So for stimulants, I would say about 3/4 of people who use stimulants take them to increase concentration, to study, and the scenario sort of plays itself out that I explained, where they're having academic difficulties. Only a small percentage of them will crush stimulants to get high. On the analgesic side, many, many more, a higher percentage, probably about 80%, will use them to get high. And a very small minority will use them because of curiosity reasons or for other reasons. And for the tranquilizers, we see a lot of self-medication going on, where there might be an underlying mental health issue. So it varies by class. And that's for the college-age population, young adult populations. We do not have that level of data at the national level. The National Household Survey, the National Survey on Drug Use and Health, does not collect that level of information for us.
And I studied 12 to 17-year-olds, so it's a younger group, and they are less likely to use any drugs, the 12-year-olds and 13-year-olds. So you see some differences. We also see differences by drug class, and they mimic much of what Dr. Arias said, with the exception being the opioids, where disproportionately the younger the child with the opioid, the more likely they say they're treating pain. Once they get older, so that now they're into 11th and 12th grade, now when they're using diverted opioid medications, they're using it to experiment, to get high, to help them sleep, but that may be because they're using stimulants or they're drinking or partying. But so it would be for sensation-seeking or recreational reasons.
Can we quantify what percentage of users are snort as opposed to crushing the medication? What percentage are snorting it? Do we know?
Of 12 to 17-year-olds?
Well, your age group, yes.
Yeah. Relatively few are snorting it. And it depends by grade. 12-year-olds and 13-year-olds are not snorting it. We see about 5 to 10% snorting it by the time they get into high school.
What about combining it with alcohol?
They all combine it with alcohol.
That's a common
They absolutely,
yes.
Our data show that any youth that is using the opioid products to get high or to sensation seek or for recreational purposes are using other drugs as well. And they're also using other prescription medications.
Would that be the same in the older age groups as well, Dr. Rivera? Yeah.
What we find is that there is always a history of excessive drinking or a history of marijuana involvement. And in some cases, they're using it at the same time concurrently during the same session. But for instance, in our data, 88% of the non-medical prescription drug users had a history of marijuana use in the past year.
So there are similarities between the 12 to 17 and the 18 and above.
There are, particularly when you get to 16, 17, and 18-year-olds. The younger ones, which I'm also studying, who are in middle school, they do look different.
Well, let me thank you and thank all of you for your testimony. I yield back.
Thank you, and I do ask unanimous consent that the information that I requested from Ms. Creighton be allowed to be included in the record. No objection? Okay, so ordered. Dr. Aria, you keep mentioning the history of use, and that they use. Do you believe? It's my belief, as a mother who just got through high school, that the powerful nature of these painkillers, that our kids do not have a chance. Can you speak to the adolescent brain, specifically what does happen when they get that tablet of OxyContin? Can you speak also to a farm party and explain what that is?
Sure. I think it's very true that the addictive potential of opioid analgesics trump what we're talking about when we see marijuana, other drugs. So what really appears to be the issue is that because it's more typical for alcohol, marijuana to be used at younger ages, there are some people who are more predisposed to using substances. We know that. And the adolescent brain is more set up to take risks naturally. And so that combination of being an adolescent and having a propensity for addiction sets up a course where you get involved with alcohol, marijuana, and then it exposes you to drug-using peers. Like I said, you begin to lose interest in other things. You get involved in prescription drugs. And then you hit a very, very highly addictive substance. And that's what you're talking about when they don't stand a chance. So if they have a propensity for addiction, plus they're in the stage of adolescence.
I have no PhD, but I beg to differ that if they have a predisposition to addiction, because I believe that every human brain has the potential to be
100% of people have some propensity for addiction.
I'm sorry, can you repeat that?
100% of people are at risk for addiction if they are exposed to addictive substances.
And then an adolescent then?
An adolescent would be even more so because of their risk-taking behaviors.
But risk-taking, a white pill to them, is a lot less risky than meth or than...
Well, what we find is that in terms of, we've done studies on perceived risk, and the risk of medications falls in between marijuana and cocaine. So they don't see it as less risky than marijuana. They see taking prescription drugs medically or non-medically is more risky than marijuana, but less risky than cocaine. So that's where it falls.
Briefly, let me just lead you to the answer that I want to hear. On another question, farm parties. It is my understanding, is it not true that kids now go to parties, throw bunches of pills into a bowl and grab whatever they can and swallow it to be risky?
We have heard of that. We have heard of that happening. We're not sure how often it happens. What we do know is that the variety of drugs used is much more, there's much more variety of different drugs used on the same occasion than there were years ago.
Okay.
That's what we know now.
Thank you. Mr. Harrison, how helpful now is the medical community? If you walk into a pharmacy, do you have the ability to tell your pharmacist, I'm a recovering addict, please don't prescribe, my drug of choice to me, or help me if I do? Do you have that ability? Are they helpful to you now?
I went through a process of a second back surgery with a 12-month sobriety, and it was difficult for me to have them administer more intravenous drugs to me because I was going through recovery. But I haven't yet attempted to gain any access since my recovery, so I haven't attempted, to talk to any doctors that I've dealt with in the past. Them knowing the severity of my injury in the past, like I said, I had built that relationship with them, and I see them from time to time in the community. And so the access was real easy. But since my recovery, I have 30 months in recovery, and I haven't yet attempted to go back.
Terrific. Well, congratulations on your 30 months.
Yeah,
Mr. Bauer, how are you finding a good avenue for your advocacy and making a difference out there? Good answer. Nice, short, and sweet. Okay, I'll yield to Mr. Butterfield for the next 5 minutes.
Thank you very much, Madam Chairman. During one of the earlier panels, and I apologize for not being here, I forewarned the chairman that I had another commitment this morning that I could not resolve. But during one of the panels this morning, a lot of time was devoted to discussing monitoring programs. I believe databases are an important tool that should be in our toolbox, but we need to treat the non-medical use of prescription drugs with many different tools, with multiple tools, and treat it as a public health issue, not just a law enforcement issue. For example, we need better education of patients and parents and friends and doctors and dentists and every person in society. Dr. Boyd, in your testimony, you mentioned better labeling as one of those tools. Can you describe what you would envision to be on a label, and would this be on all prescription drugs or just those that are the most risky if diverted?
Well, I'm also a nurse, and I would like to see better labeling on all medications, but let me direct my attention to the control medications that are more likely to be diverted and abused. I would recommend that we label them that it is unlawful to distribute them. Many of the kids that I interview do not know, and parents do not know, that mother of the homecoming who was going to homecoming, she didn't know she was doing something illegal. They should know it. It should be labeled on the bottle. It should also be, there should also be directions on how to dispose of extra medicine that is left in the bottle so it's not sitting in the medicine cabinet. And finally, not only should they know where to dispose it and that it's unlawful to distribute it, but they should also know that it has addictive potential and abuse potential. We label, many medications I've gotten have been labeled more fully than the medications that are controlled.
All right, let me come to the other end of the table, Ms. Creedon. Aside from labeling, and I'd like Dr. Boyd's assessment of this, but aside from labeling, what can we do to increase public awareness of prescription drug abuse? We've got to become more proactive so other families do not have the tragedy that you've experienced. What can we do? Yeah.
You know, that's a really good question. I don't know the answer yet, but I intend to hopefully be able to make a difference by this organization that I've started, and our goal is to reach out, first of all, to students in high schools, middle schools, college age, the parents, and I really would like to reach out to the medical community as well, because that was a specific problem in my son's, well, that led up to his death. In these 7 pages, I document, if I could just take a minute in the beginning, where my daughter and I had a face-to-face meeting with the director of the medical facility, where we said to him, Ryan has an addiction problem. And like I said, because of privacy laws, we were not able to speak about certain things, you know, because of breaking laws. But he did tell me that he would go and speak to the physician that Ryan had an appointment with 2 days later. That conversation apparently never took place, and I just feel that if he would have taken our conversation seriously, coming from a family member of Ryan's history of drug abuse, that could have stopped the other 6 pages of his hospitalizations and everything else that went on. So for me particularly, I feel that the medical community doesn't take addiction seriously because maybe they are just not aware, you know, of what a few pills can do to somebody. In my son's case, it led to his death.
What about public service announcements on TV channels that are watched by young people?
That's one of the things that we hope to be able to do.
Yeah, MTV and BET and some of the other channels.
Absolutely.
Yes.
There are some things already being done directly to young people on the websites and things that they listen to about the dangers of, you know, prescription drug abuse. So yes, that would be a...
We need to do it, and we need to do it repetitively.
Exactly.
One thing we've learned in Congress, if you say something over and over and over again, people will listen and sometimes believe it.
That's what I read in all the
Yes.
educator material that I've been researching lately, is that it does have to be repetitive, and so it would almost mean being present on a high school property, like on a weekly basis, just over, you know, just over and over telling them the dangers of the drugs before they go to a party on Friday night.
Thank you. Thank you again. I yield back.
All right, thank you. We'll do 5 more minutes, and then we'll conclude the panel and move on to the next. Unless you'd like another 5, I'm certainly fine with. I just don't want to make you do it. I was so busy listening to what you were saying.
We're going to have votes in about,
Okay.
about an hour. Yes. Yeah.
Dr. Boyd, back to you. Labeling. My understanding through the years of my research on OxyContin that actually the label was what turned kids on to the ability for the misuse. I think that labeling is not nearly, it's not going to be the answer. I don't know how old your son is, but I believe that it goes back to me to the DEA and the FDA and the supply chain and figuring out how this stuff is getting out there and why we're buying back hundreds of tons of this, hundreds of pounds of this stuff, hundreds of whatever the astronomical number is. So it's got to be beyond labeling. Let me just jump to Ms. Creedon again. Again, your testimony is terrific, but you spoke to the medical community and your frustrations with them. But since Ryan's death, you've worked with the medical community and the doctors overseeing the HMO. And it's my understanding that they did learn a lot from you and that they've agreed to change their prescribing practice for such powerful painkillers. Is that true? And have you followed up on that? That you are able to actually educate in your community, your HMO, and get a change?
Yes, that is true, and I was very happy that they were receptive to hearing the information. I printed out a lot of information from the internet and shared it with them, and in fact the medical director told me that he took the information that I gave him and presented it in front of a staff meeting that they had, and they, in fact, after my meeting, made a policy within their organization that covers approximately 3,000 physicians and over 300,000 members, that those physicians could no longer prescribe OxyContin for the patients unless they had fourth-stage cancer and they had tried everything else. So I feel that was a huge victory, that the education that I gave them made that change. And I haven't been able to follow up with the outcome. I intend to do that, but I don't know right now if that's still happening.
I congratulate you on that, and it goes to Ms. Rivero in your testimony. You say the same thing. Actually, you advocate. You say that your son had never been treated for any of the conditions listed on the doctor's record as a basis for her prescription for the powerful painkillers. Were you surprised by how easy it was for him to get access to those medications?
Not only surprised, I was shocked. I had never heard the term pill mill. I had not heard about dirty doctors. This last year has been a complete education, a complete upscale education for me. Shocked, absolutely shocked. And I've learned that that is the case throughout the country. I talk now to parents all over the place, California to Florida, and it's happening. There are so many unscrupulous doctors out there that are giving it out. They're in a pill mill kind of environment, but it's not just those doctors. It's also those that are really well-meaning, but they are not really, I don't think, well educated about pain management treatment. I've been told, I don't know if it's true for sure, but I've been told that doctors get less pain management training than veterinarians do. And that's horrifying to think about, but if it's true, my gosh.
Would you agree with that statement, Dr. Boyd, Dr. Arya? Do you know about the level of training that physicians do get before they can prescribe these things?
I know it's gotten better, but I know that I can speak to the addiction medicine side. They really are not given proper training at the graduate level, graduate medical education on addictive disease.
Dr. Boyd?
I agree with that. It's just inadequate.
Thank you. And I will just use my last minute. I think we agree with Ms. Creedon, Ms. Rivero, on trying to limit the scope on when it is prescribed. I think that's hopefully something we can push for in Washington. But I really just want to thank you all very much for your commitment and your advocacy to this. And I don't know where it's going to go. I'm frustrated last night in my research to see that there was a Senate hearing in 2002 that's very much like the one we're holding today. I think that's frustrating, and I think we're failing. It's a tough time for budget cuts, and we all have questions on how we spend our money. But we can do a better job, and I think the American people want an effective government, and in this case, it's not being effective. So I look forward to working with each and every one of you, and if you had another 5, I'm willing to yield to the gentleman. If not, we will take a quick recess and see the next panel. Thank you all very much.
dude, I'm getting out of here. I can't sit here.
The first will be, thank you, whoever did that. First up will be Sean Clarkin, Executive Vice President of the Partnership for a Drug-Free America. Also joining us is General Arthur Dean, Chairman and CEO of the Community Anti-Drug Coalitions of America. Then we'll have Dr. Koster, Senior Vice President of the Generic Pharmaceutical Association. Our fourth panelist is Kendra Martello, Assistant General Counsel, Pharmaceutical Research and Manufacturers of America. Also testifying, Michael Mayer, President Frank Mayer and Associates. And our sixth witness is Patrick Coyne, registered nurse, testifying on behalf of the Oncology Nursing Society. Welcome, everyone. Thank you very much for being here today. I think you know the drill, 5 minutes, green, yellow, red. In America, we generally know what that means. So just please make sure you press the microphone to turn it on. And Mr. Clarkin, you are recognized for 5 minutes.
Chairman Bono Mack, Ranking Member Butterfield, members of the subcommittee, thank you for inviting me to testify about the problem of prescription drug abuse and the diversion of prescription medicine. The abuse of prescription medications, legal substances of tremendous benefit if used appropriately, is the single most troubling phenomenon on today's drug landscape. According to the 2010 Partnership Attitude Tracking Study, PAT study, 1 in 4, 25% of teens report taking a prescription drug not prescribed for them by a doctor at least once in their lives, and more than 1 in 5 teens, 23%, has used a prescription pain reliever not prescribed for them by a doctor. Why have we as a nation not been able to reduce this highly risky behavior? There are several reasons, many of which we've already heard today. The first is ready access. These substances are readily available to teens in their own medicine cabinets and the medicine cabinets of friends and family, and very often they're available for free. Nearly half, 47% of teens in our PATS survey say that it's easy to get these drugs from parents' medicine cabinets, and more than a third say it's available everywhere. Another reason is low perception of risk. The low perception of risk that's associated with abusing prescription drugs. Partnership research shows that less than half of teens see great risk in trying prescription pain relievers such as Vicodin or OxyContin that a doctor did not prescribe for them. Low perception of risk coupled with easy availability is a recipe for an ongoing problem. Third reason that we've heard a lot about, especially from Dr. Boyd, is the motivation to abuse. We have traditionally thought of teens abusing illegal drugs and alcohol either to party or to self-medicate for some serious problem or disorder, adolescent depression, for example. But our research, like Dr. Boyd's, shows that teens appear to be abusing these drugs in a utilitarian way, using stimulants to help them cram for a test or to lose weight, pain relievers to escape some of the pressure they feel to perform academically, tranquilizers to wind down at the end of a stressful day. Once these substances have become integrated into teens' lives and abused as study or relaxation aids, it may become increasingly difficult to persuade teens that these drugs are unnecessary or unsafe when taken without a prescription. The fourth reason, and this is a particular focus of the partnerships, is the lack of parental activism in prevention of this behavior. Parents, who are usually our most valuable ally in preventing teen drug use, find it hard to understand the scale and the purposefulness with which many of today's teens are abusing medications, and it's not immediately clear to these parents that the prime source of supply for abusable prescription drugs may well be their own medicine cabinet. Many parents themselves, moreover, are misusing or perhaps abusing prescription drugs without a prescription. In research that we did in 2007, 28% of parents said that they themselves had used a prescription drug without having a prescription for it, and 8% of those parents said that they had given their teenage child a prescription drug that was not prescribed for them. Finally, the reason we've not been able to reduce teen abuse of prescription medications is that our efforts as a nation have been inadequate, at least to date. There simply has not been sufficient public attention or resources dedicated to this threat. The backdrop to all of this is that the national drug prevention infrastructure has been eroding for the past few years as the budget for the National Youth Anti-Drug Media Campaign has shrunk significantly. The Safe and Drug-Free Schools and Communities State Grant Program has been eliminated, and changes have been proposed to the State Prevention and Treatment Block Grant that could put prevention funding in jeopardy. With dwindling resources, it's impossible for government to be able to mount the kind of effort that's necessary. We know that when there is a well-funded effort to educate parents about the dangers of prescription drug abuse, we can increase awareness and we can make a difference. In the first half of 2008, the Office of National Drug Control's Policy's National Youth Anti-Drug Media Campaign devoted $14 million, with the Media Match was a $28 million effort, to a parent-targeted campaign aimed at raising awareness about the risks of medicine abuse and motivating parents to take action. The campaign, actually, in terms of parents' perceptions of the problem and intent to take action, was demonstrably successful. This shows that a major public education campaign can help to turn the tide on this entrenched behavior. The media campaign's funding is in jeopardy and may even be eliminated in the coming years, so we can't assume that that campaign will be around to deliver this message. The private sector will need to help finance a campaign of the magnitude necessary to change the attitudes that underline this behavior. While the partnership is grateful for the unrestricted support we have received from a number of pharmaceutical companies, if our nation is going to reduce teen abuse of prescription medication, we need to step up efforts dramatically. We need a sustained multi-year effort funded by the pharmaceutical industry, the generic drug manufacturers, and other key stakeholders to, first, support a major independent paid media campaign alerting consumers to the risks of abusing medicine and the importance of safeguarding and safely disposing of medicine. This effort might include tagging the pharmaceutical industry's large inventory of direct-to-consumer advertising and pointing viewers towards an objective and comprehensive online prevention resource. Second, we need to educate and enlist prescribers, pharmacists, and other healthcare professionals. Third, we need to educate policymakers so that we can promote policies that will help reduce both the supply of and the demand for prescription drugs of abuse. And finally, implement an evaluation tool that would measure and hold this program accountable. In conclusion, at the partnership, we believe that the abuse of prescription medications, legal substances of great benefit when used properly, is the single most troubling phenomenon on today's drug abuse landscape. We appreciate the time and the attention that the subcommittee is giving to raising awareness and looking for ways to reduce the abuse of prescription drugs in our country. The partnership at drugfree.org stands ready to work with the subcommittee on this and other substance abuse matters. Thank you very much.
Thank you, Mr. Clark. And General Dean, you're recognized for your 5 minutes.
Chairman Bono Mack, Ranking Member Butterfield, and other distinguished members of the subcommittee, thank you for the opportunity to testify today on behalf of Community Anti-Drug Coalitions of America, CATCA, and our more than 5,000 community coalitions nationwide. I am pleased to provide you with CATCA's perspective on the complex problem of prescription drug abuse. CATCA has been on the front lines addressing prescription drug abuse for nearly 10 years. We have hosted town hall meetings, developed publications and toolkits for coalitions, and produced television programs on this subject. In 2009, we were fortunate enough to conduct a rally with over 1,000 community leaders on Capitol Hill to raise the awareness of over-the-counter as well as RX abuse. CATCA recognizes that the misuse and abuse of prescription drugs is a multi-dimensional problem that demands comprehensive, coordinated solutions at all levels, local, state, and national. Population-level changes in substance use, including prescription drug abuse, can be achieved by a comprehensive, data-driven approach. This approach mobilizes key community sectors. They work together to educate, reduce access and availability, and change perceptions as well as social norms. Where this infrastructure is in place, communities have successfully prevented and pushed back against a variety of drug problems, such as marijuana, methamphetamines, K2, and the misuse and abuse of prescription drugs. The Drug-Free Community, DFC program is the best example of a comprehensive community-wide approach being taken to scale nationwide. Since 1998, the DFC program has been a central bipartisan component of our nation's demand drug reduction strategy. A recent evaluation of the program found that youth drug, alcohol, and tobacco use are significantly lower in DFC-funded communities than in communities without a DFC coalition. CATCA trains DFC grantees and other community anti-drug coalitions to execute 7 evidence-based strategies to affect community change for drug use. Coalitions across the country are implementing these strategies, and these strategies range from raising awareness to changing policies, and they are achieving measurable results and reducing local prescription drug abuse rates. In the interest of time, I would like to share just one example from Caribou, Maine. The Aristook Coalition used a multi-sector approach to identify prescription drug problems and to craft a strategic action plan to address them. The coalition did the following. 1, they implemented a comprehensive social marketing campaign. 2, they provided training to healthcare providers about proper prescribing. 3, promoted and funded a prescription drug take-back program. And 4, created a monthly mailer for healthcare providers that lists individuals charged with prescription drugs-related crimes in their communities. As a result of this data-driven multi-sector approach, the coalition achieved significant outcomes. Through the coalition's effort, the county has maintained lowest rate of past 30-day prescription drug use among high school students. Similar coalitions examples are highlighted in my testimony, and I would invite those to your attention. CATCA's primary message today is to this committee is that community coalitions are evidence-based and effective and should be utilized as a major component of any prescription drug prevention strategy. We recommend that the coalition model be implemented in concert with a number of other key approaches. For example, CATCA supports the expansion of an effective prescription drug monitoring programs to ensure adequate coverage in every state. The data from these programs can also help identify hotspots and appropriately direct the attention to other resources. We need enhanced education opportunities for training for medical and dental professions. We also need increased awareness and education about the danger, proper storage, and disposal of drugs. We support enhanced opportunities to make prescription take-back programs routinely available. We strongly support increased law enforcement to remedy such things as pill mills. Our nation needs to embrace and enhance all these strategies. We need to expand the number of DFC-funded communities. And finally, we need to increase training at the local level so that more communities can effectively address this major public health and safety threat. I thank you for the opportunity to testify before you today and applaud you for your great work. Thank you.
Thank you, General, and we're honored that you're here, and I thank you for your service and that you came in under the wire, because there's one person I couldn't gavel down, and it would be you, sir.
And thank you for your great support and on a continuing basis. We appreciate it very much.
Thank you. I look forward to our continued work together. Dr. Costa, you're recognized for 5 minutes.
Thank you. Good morning, Chairwoman Bono Mack, Ranking Member Butterfield, Congressman Lance, members of the subcommittee. I'm John Koster, Senior Vice President of Government Affairs at the Generic Pharmaceutical Association and a licensed pharmacist. On behalf of GPHA and our member companies, thank you for calling this hearing and for the opportunity to testify. Let me begin by giving some background on the role of the generic drug industry in the United States. About 75% of all prescriptions are filled with generic medications, although that percentage does vary by therapeutic class. We are proud that our industry helps make high-quality, safe, effective prescription medications more affordable for millions of Americans while saving the healthcare system billions of dollars each year. GPHA's member companies manufacture FDA-approved generic versions of brand-name drugs in all therapeutic categories, including prescription painkillers. We are as concerned as the members of this committee when medications that are made to improve lives or alleviate pain are abused. We believe that addressing this issue, as you've heard from the previous witnesses, will require continued coordination among federal and state agencies, state, local, and federal law enforcement, health professionals, drug manufacturers, pharmacists, patients, and their families. Because it is a multifaceted problem, it requires a multifaceted solution. As we work together to shape public policy to end the misuse of pain medications, we must recognize that the overwhelming majority of individuals, including millions of seniors and cancer patients, do rely on these important drugs for their proper pain treatment. We are absolutely committed to the safe and reliable manufacturing and delivery of generic drugs. As an industry, we have invested millions of dollars into technologies and delivery systems to help assure that our products reach their destination safely and securely. For example, with respect to opioid pain medications, the DEA has a closed system of distribution to prevent diversion. Our industry works with the DEA to assure that these products do not fall into the hands of abusers. For example, the DEA administers drug allotment and accountability systems to assure against the loss of diversion of controlled substances. Recent studies suggest that the problem of prescription drug abuse stems not from drugs that have escaped the legitimate supply chain, but those or have been obtained illegally through the black market, but instead from those that were legally prescribed and available in the home. Why are these medicines sitting in medicine cabinets? Shouldn't patients have already taken them? It is not uncommon to find many medicine cabinets in America are stocked with unused prescription drugs. Some of these may be for mild conditions such as allergy, while others may be unused medications that were prescribed to treat the discomfort of a surgery. Many Americans have no recourse to return these unused medications, especially controlled substances, because federal law prohibits the transfer of controlled substances from an ultimate user to anyone other than law enforcement. This will soon change as DEA implements the Safe and Secure Drug Disposal Act, which will permit ultimate users, such as patients with excess controlled substances in their medicine cabinets, to return them to DEA registrants, such as willing pharmacists, so they can be destroyed. What has our industry been doing to help address this problem? In general, we have tried to support efforts that are dedicated to raising awareness to the dangers of prescription drug abuse, as well as the need to properly dispose of unneeded or unwanted prescription medications. We think education is a key component to this. For example, we support efforts such as the American Medicine Chest Challenge, which is a community-based public health initiative with law enforcement partnership to raise awareness about the dangers of drug abuse. We are pleased to let you know that we will be partnering with pharma to produce a public service announcement that will promote the upcoming DEA Take Back Day on April 30th, which we hope will be as successful as the one from last fall. We are also a board member of NCPI, the National Council on Prescription Information and Education, a broad-based coalition addressed on raising awareness about prescription drug abuse. For example, NCPI most recently developed a college resource kit to help educate students about the dangers of prescription drug misuse. In addition, over the last few years, our industry companies have focused efforts in this area by joining with the brand name industry, patient groups, and the FDA on working on a REMS program for long-acting and extended-release opioid medications. REMS are special programs that are used by FDA to help prevent adverse outcomes in patients. At this point, I don't believe the FDA has implemented that program yet. Madam Chairwoman, we applaud you for the countless hours you have devoted to raising awareness about this issue and the great work you have done. With the cooperation of physicians, law enforcement, and others, we can expand education efforts, keep our supply chain safe and secure, and help ensure that patients and family members are not alone in this fight. We thank you for holding this hearing, and I would be happy to answer any questions you may have.
Thank you, Dr. Koster. Ms. Martello?
Good morning. Thank you, Madam Chair, and distinguished members of the subcommittee, Ranking Member Butterfield and Congressman Lance. My name is Kendra Martello, and I'm pleased to offer this testimony today on behalf of the Pharmaceutical Research and Manufacturers of America, or PhRMA. PhRMA's members represent America's leading pharmaceutical research and biotechnology companies. Last year, our members alone invested over $49 billion in discovering and developing new medicines. Industry-wide, research and investment reached more than $67 billion last year, a record. The prescription medicines our members research and develop are life-saving and life-enhancing medicines that allow patients to live longer, healthier, and more productive lives when used appropriately and as intended. It's important, as we consider the non-medical use of prescription medicines, that we also balance the need to maintain patient access to these medicines for legitimate medical use. We believe addressing the public health problem of prescription drug abuse is a shared responsibility. It requires a comprehensive, consistent, and sustained approach and commitment from a wide range of stakeholders, including prescribers and pharmacists. No one manufacturer, brand or generic, recognizing that approximately 75% of the prescriptions dispensed are for generic medicines, no one trade association, and no one stakeholder group is solely responsible for implementing a solution that will truly be effective. We all must work together to achieve a common goal. And PhRMA and our member companies are committed to being part of the solution. An important part of our educational message surrounds the appropriate use of medicines, which can reduce health care costs overall. Data also show that the majority who misuse or abuse prescription medicines do obtain them from a friend or family member. We believe education can have a significant impact in helping to inform the public and reducing the overall rates of prescription drug abuse. We've developed 4 simple messages as part of our educational effort on this important issue. First, take your medication exactly as prescribed. Second, store all medicines in a safe manner out of the sight and reach of children and adolescents in particular. Third, don't share your medicines with anyone, including friends or relatives. And fourth, promptly dispose of any unused medicine in a safe manner, either through the household trash or an appropriate take-back program, such as one administered by the DEA. In fact, to help further this last message, PhRMA partnered with the U.S. Fish and Wildlife Service and the American Pharmacists Association in 2007 to create the Smart Disposal Program, which educates consumers about how they may safely dispose of most medicines through the household trash. PhRMA and our member companies have also undertaken significant educational efforts regarding prescription drug abuse. For example, we've recently worked with the Washington Health Foundation and the State Attorney General to develop education for college students, and with Dare America to help educate students in grades 5 through 12. We also believe specific educational efforts must be targeted towards prescribers and pharmacists and could help them to detect and refer for treatment those who may be abusing prescription drugs. Other ideas that could have a significant impact on reducing the rate of non-medical use of prescription drugs. First, increase the use of and improvements to state prescription drug monitoring programs, which can be an important tool in preventing and detecting abusers and referring them for treatment. Second, reauthorize NASPR, which provides grants for the state monitoring tool and which is legislation that PhRMA has supported. Third, increase penalties for and enforcement against pill mills, medicine diverters, and those who go outside the legitimate medical supply chain, including rogue internet drug sellers. Fourth, work with FDA and others to facilitate the development of medicines to treat addiction and mechanisms to make medicines less susceptible to abuse. And finally, work with the DEA as it develops regulations to allow ultimate users and long-term care facilities to return controlled substances for disposal. In conclusion, prescription medicines, when used as prescribed, are critical to improving and extending patient health. However, when they are misused or abused, they can be dangerous and even deadly. No one solution to this public health problem exists. Education is of critical importance, and it's a key first step, but we must not stop there. And all stakeholders have a role to play in helping to develop solutions. We're committed to working with the subcommittee, members of Congress, and other stakeholders on this important public health issue. Thank you.
Thank you. Mr. Mayor?
Madam Chair, Ranking Member Butterfield, and Mr. Lance, I appreciate the opportunity to appear before you today. I'm here today representing MedReturn. MedReturn is a subsidiary of Frank Marin Associates, an 80-year-old family-owned company in Grafton, Wisconsin. Our core business is designing and manufacturing in-store displays, merchandisers, and interactive kiosks for Fortune 500 companies. Our involvement in the issue of prescription drug abuse stems from the commitment to provide a safe, secure, sustainable, and environmentally friendly way to help law enforcement agencies and communities collect unwanted or expired prescription medication and over-the-counter drugs. The genesis of MedReturn began over 3 years ago when I challenged the associates in my company to research and develop new ideas. The challenge was called WIT. Wish I'd thought of that. As we began investigating the prescription drug disposal issue, we quickly became aware of the magnitude of prescription medication and drugs that sit unused or expired in our medicine cabinets. We began researching and looking for existing take-back programs and realized there was no consistent method or program available. Over a 2.5-year period, we developed, prototyped, presented, tested, improved, and produced the MedReturn Drug Collection Unit. Noting the importance of education, we incorporated a sizable graphic panel that states and communities can customize. We launched MedReturn at the International Association of Chiefs of Police Conference in October 2010. To date, our drug collection unit has been placed in 50 police and sheriff's departments across 11 states. We helped implement only the second county-wide ongoing drug collection program in the U.S. Attached statements from law enforcement agencies confirm the positive response of their communities to sustained drug collection. Lieutenant Tim Doney of the Medford, Oregon Police Department notes usage of their program is so heavy they are emptying the collection unit at least 4 days a week. Other email feedback we have received illustrates the demand for permanent medicine return programs. Sheriff David Peterson of Waushara County, Wisconsin reports collecting 200 to 250 pounds of medication in 3 months, and Lieutenant Wayne Strong believes the Madison, Wisconsin Police Department has collected 230 pounds in that same time frame. What started as an effort to supplement our core business has quickly evolved into a passionate desire to be a small part of the solution to the prescription drug abuse problem. We have devoted and continue to devote significant amounts of time and money to let state and local law enforcement agencies and community groups know we are available to answer inquiries. We know the DEA is working toward finalizing regulations that implement the Secure and Responsible Drug Disposal Act of 2010. We have talked with hundreds of law enforcement officers. Many of them are asking us how to implement their programs. Others believe the collection and disposal process is too complicated. Others insist on recording and inventorying all collected medications, and others don't realize the scope of the problem. We believe a lack of understanding may be a deterrent to establishing a permanent take-back program. We also find a varied interpretation of what constitutes safe disposal. Some departments accept pills in the bottle, while others want pills placed in plastic bags. Others will hold the collected contents until the annual take-back day. One officer admitted he collected the drugs but then flushed them down the toilet. Ideally, we would like to refer potential users of MedReturn to a central resource that outlines federal and state requirements and best practices. At MedReturn, our vision is a sustainable nationwide program as widely available as plastic, glass, and paper recycling are today. By our calculation, there are some 30,000 communities that could benefit from a take-back program. We're in the process of seeking corporate or foundation partners that might speed this process. We appreciate the amount of attention prescription drug abuse is receiving from members of Congress and the administration. We hope you will continue to consider the challenges of those who want to establish a sustainable drug collection program at the grassroots level. We stand ready to serve as a resource in any way that is appropriate. Thank you.
Thank you, Mr. Mayor. Mr. Coyne? Please remember to turn your microphone on.
Good morning, Madam Chair and distinguished members of the subcommittee. It is a great honor that I testify today regarding pain management and the potential implications for patients in need of pain relief from diagnosis to survivorship. My name is Patrick Coyne. I've been a clinical nurse specialist for over 25 years, focusing on pain management and symptom control, typically in cancer patients. I'm the clinical director of the Thomas Palliative Care Services within the Massey Cancer Center at Virginia Commonwealth University in Richmond. In my role, I care for individuals on a daily basis who are dealing with life-limiting diseases and significant issues with pain. The patients I care for are from all walks of life, living in both urban and rural areas throughout the Commonwealth. I also teach in the schools of nursing and schools of medicine in our university and beyond. Today, I represent the Oncology Nurses Society, ONS, the largest professional oncology group in the United States, composed of more than 35,000 nurses and other healthcare providers. I would be naive not to recognize that the problem of opiate diversion is a very severe one and can destroy both patients, families, and communities. More must be done to treat this significant issue. However, what about those patients who live daily with intractable, unrelenting pain? Daily, I encounter patients who will not see their next birthday and often travel hours to see someone within our institution for appropriate analgesia because their local healthcare provider is uncomfortable with prescribing the medications the patients need or fearful that their license may be revoked for using too much opiate pain medication. This population of patients is frail, dealing with countless issues, which I hope I never have to, and often has no voice. I hope to be their voice and ensure their comfort. I also wish to support their privacy so that nobody needs to know about their illness unless they choose to release this information. The challenges within pain management are many. Individuals respond differently to different medications, including oxycodone. Many clinicians receive far inadequate training in prescribing analgesics, assessing pain, and other treatment options, and have false concerns regarding the role of analgesics. Certain areas in this country have limited resources for managing pain well. We know adequate pain management, as demonstrated in several studies, can increase both survival and quality of life for patients with life-limiting diseases. Caregivers often suffer from depression and financial impact when pain is poorly controlled. Pain is a serious and costly public health issue. Unmanaged pain is a tragedy. What really seems to be the tragedy is the this patient population may suffer because of those conducting illegal activities. Pain management is challenging in any population. Cancer patients fear pain, as do their families. But what of cancer survivors who suffer daily in pain but are disease-free? Consider those individuals from pain from poor cardiac output, sickle cell disease, or burn injuries as examples of just a few populations of patients who may be at risk without the availability of certain opiates. Addiction and misuse of analgesics is exceedingly rare in patients in pain, yet they may carry the burden and suffer the decision made by others. All discussion about the issue of opiate pain medications need a balanced exploration of the risks, but also the benefits of the medications when used appropriately. Limiting a pain medication, any medication, might take a very safe option away from countless patients living with moderate or severe pain. Education of prescribers is clearly needed to better assess pain and implement appropriate treatment options, but limiting options may ruin many individuals' lives. I have treated many patients with oxycodone, OxyContin, and other analgesics, mostly cancer patients, who have not tolerated other medications or did not get adequate relief from other opiate or non-opiate pain medications. Patients and their families need better education and support regarding the safe and appropriate use of, storage, and disposal of medications. The needs of countless patients suffering in pain need to be part of this and any discussion. I want to thank you for your time and commitment regarding this exceedingly important subject. I've devoted my life to pain management, and I fear that many patients I care for may suffer if poor decisions are made regarding pain management. And I welcome your time and questions. Thank you very much.
Thank you to all of the panelists for your expert testimony. I think, Mr. Coyne, first of all, I applaud you in your efforts and think that we share the same goals. My father was suffering from last stages of cancer just a couple of years ago, and I watched him go through it, so I appreciate what you see in a clinical setting. But at the same time, I've seen people suffering from opiate withdrawals. And so I, too, care about those people and the pain that they suffer and the life of living with that addiction. Once you're an addict, as you know, you're an addict for the rest of your life. So hopefully we can continue to work to make sure that the people who you need to treat are treated to the best of your ability, and we can also keep the hands out of the drugs out of the hands of the bad guys. And it goes to Ms. Martello. I keep hearing this reoccurring thing that it's coming from friends and family and medicine chests. And I can't believe that y'all are serious when you think that's the big problem. Just this week there's an article about another prescription drug sting with 15 arrested in San Diego, California. Now, I will grant that they were arrested because they had prescription pills that they didn't have prescriptions for, but they also had cocaine, methamphetamine, and other street drugs. But can we take our head out of the sands and quit acting like it's all grandma's medicine chest and admit the fact? And let me just go to Dr. Koster. You are a licensed pharmacist. In 2008, the Partnership for Drug-Free America, or drugfree.org's president, Steve Passerb, and he's Steve Passerb, he said in a Reuters interview that, and I quote, "OxyContin is pharmaceutical heroin. There's really no difference between the two." Do you care to explain the difference pharmacologically between OxyContin and heroin, how far off it is?
To be honest, Madam Chairman, it's been so long that I've been in pharmacy school, I'd probably get it wrong if I did it. So if you'd like, we can provide you an explanation after, but at this point, I probably wouldn't be able to do it in a way.
Well, it's my understanding it's one molecule off. I mean, that would be a fair characterization, and you certainly can submit that to me in writing later. But would you say that OxyContin and heroin, as consumed, the way they are consumed by the human body, the only difference is the delivery mechanism?
Again, I wouldn't be able to comment on that. From a pharmacological perspective, I wouldn't want to give you any incorrect information or inaccurate information. So, again, if you'd like, I'll be happy to provide whatever I can in writing after the hearing.
Well, it's my belief and my contention that they are pretty darn near the same. But to both you and Ms. Martello, you keep using under-adherence and medication noncompliance and those terms in your testimony. When you talk about the problem with under-adherence and noncompliance, are you lumping in therapeutics, antibiotics, other drugs into that category? Can you really say that there's a problem that people are not taking all 30 days of OxyContin when they're prescribed it?
I think appropriate use of medicines can go a long way to helping patients improve their health conditions. And as I said in my testimony,
including 30 days of OxyContin.
This is something that I think, as we've heard throughout the testimony this morning, there are a variety of stakeholders who have a role to play.
Now, let me get back to this. It's a simple question. Are you saying that it's for the patient's benefit that they take 30 days worth of painful painkillers like OxyContin?
I think healthcare professionals are on the front line of this every day, and I think part of the educational effort that we can engage in.
No, this is like a yes or no. This is a yes. This is and to Dr. Koster too. It's a yes or no.
I mean, I can give you a personal experience if this helps. I had surgery a couple of years ago, and when I left, the physician said, "Here's a prescription for," I can't remember if it was 30 or 50, for OxyContin. I went to get it filled, and he said, "If you need them, take them." So I guess he thought that in my case I might need 2 or I might need a week's work. So I think, and again, not to justify how these drugs are used, but some people, I guess some physicians feel like, I'll give you this quantity, and if you need them, take them. If you don't, they don't really tell them what to do with them. So I don't know if it's a yes or no answer, but in terms of a personal...
No, the question is extending their life, extending the quality of life. You're lumping this in, it seems to me, with therapeutic drugs or antibiotics or something when you talk about under-adherence of drugs.
Well, I mean, again, in terms of, like, if you're taking a blood pressure medication where you absolutely have to take it every day, or you have a cholesterol medication...
But we're not focused on those drugs today.
No, I know
but we
that,
keep saying under-adherence, under-adherence.
I think in the case, and again, I'm not a prescriber, but in the case of pain, oftentimes you get prescribed a quantity of medication because the physician doesn't know, for example, how you're going to tolerate a certain procedure. He might say, you might need these for 5 days, you might need these for 10. Again, I'm not justifying this. I'm just saying, and as a pharmacist who's seen a lot of patients come in and fill prescriptions for pain, where the patient says, I may not need all these, or why did the doctor give me all these, you're trained to tell the patient that the physician probably gave these to you because he's not sure how many you're going to actually need.
Well, my time has expired, but we'll come back to that, and I'm sure Mr. Mayor is very appreciative of the over-prescriptions because he's Mr. Butterfield, you recognized for 5 minutes.
Chairman, as we have heard, 70% of non-medical prescription drug users get those drugs from family or friends. It can be given to them, it can be sold, they can actually, unfortunately, steal it from others. We also know that the family medicine cabinet is bulging with unused and no longer needed medicines. Disposing of these medicines properly must be a priority, and we must work to reduce their negative impact on the environment. When people do not have a safe place outside of the home where they can dispose of their unused drugs, they typically flush them, causing them to ultimately end up in our waterways. Question: I understand that a number of communities have created take-back days in which medicines are safely collected by law enforcement. Also, the Secure and Responsible Drug Disposal Act, sponsored in the House by Mr. Inslee of Washington, will allow more people and places to collect these unused medicines. This question is for Mr. Clarkin. Does the partnership that you represent have any examples of times when a take-back operation works particularly well?
Not specific instances in specific communities, but we, first of all, support the whole take-back program that the DEA has spearheaded, and the most recent take-back initiative, I think it was pointed out earlier, was terrifically successful in terms of the quantities of drugs that were actually brought back and safely disposed of. And we look forward to supporting the DEA at the April 30th take-back.
Thank you. Next to General Dean, thank you for your service to our country. What branch were you a part of? All right. Ever stationed at Fort Bragg? All right. According to, and thank you for that, according to reporting by the North County, California Times, almost said North Carolina, the North County, California Times, a couple of years ago, military doctors wrote service members nearly 3.8 million prescriptions for pain medications, up from less than 900,000 10 years ago. The Defense Department estimates that abuse of prescription drugs in the military is double that of the general population. First of all, do you agree or disagree with that? That military drug abuse is more and probably twice as much?
Excuse me, General, would you please turn your microphone on?
Okay, back.
Thank you.
I agree that the military has a significant problem with this issue. I don't have the exact statistics on it.
But you have no reason to disagree with that statistic.
I have every reason to agree with that.
All right. And it appears that one study in 2009 even found that 20% of Marines had abused prescription drugs, mostly painkillers, at some point in the previous year. Our active service members face significant anxiety overseas, and many live through pain every day when they are on duty. But if they develop a physical dependence or addiction to prescription drugs, it can follow them back home to their civilian life, and I have seen it all of my life. General, what should the administration do with regard to training veterans hospitals to be on high alert for this type of abuse?
I think it's a multifaceted approach that needs to be taken in order to assist our military members and their families in the communities that they reside in. I've had some discussion, my organization has, with the Army. I have another meeting scheduled with them in the very near future to address just this issue of helping them be more holistic in their approach of dealing with this issue that is not only social focused but also for the family members as well as the other civilians as well.
Are there other programs? I have about 40 seconds left. Are there other programs geared to prescription drug abuse by veterans? For example, veterans may receive health insurance from the federal government. Are the insurers instructed to be on the lookout for abuse, and not simply for the sake of law enforcement, but really to help the veteran?
The answer is yes. I have a board member who runs the VA Substance Abuse Center of the big VA facility in Atlanta, Dr. Karen Drexler, and the VA has programs, but the resources and the number of people that they have, in my opinion, I'm not speaking for the VA, needs to be expanded, and there needs to be greater information provided, and there need to be greater educational programs. But do they have the programs? Yes. But my understanding would be that there needs to be a substantial enhancement in those programs.
Thank you. Thank you, one and all. I yield back.
Thank you, Mr. Butterfield. The chair recognizes Mr. Lance for 5 minutes.
Thank you very much, Madam Chair, and good afternoon to you all. I find this testimony very interesting. I don't have the honor of representing Fort Bragg, but I do represent the district in the United States that has more medical and pharmaceutical employment than any other district in this country, and certainly this is an issue in the district as well as across the country. To Dr. Coster or to Ms. Martello, or to both of you, regarding the risk evaluation and mitigation strategy at the FDA, based upon your expertise, do you feel that it has contributed to the mitigation of prescription drug diversion? And has there been any unforeseen consequence, such as access issues for patients?
When we look at policies in this area, certainly balancing the need between legitimate patient access and ensuring that the product's benefits continue to outweigh its risks is an important public health consideration, and I think that those are the issues that are currently being grappled with. The FDA has a variety of tools in its arsenal to make sure that the product continues, the benefits continue to outweigh the risks of any product.
Dr. Coster?
Yeah, sure. That's an excellent question, Congressman. There's so much focus and attention that's been placed on this program, and even though it's not yet been fully implemented by the FDA, I think just by the attention it's received, it's caused physicians to maybe look more closely on how they prescribe and patients on what they do in terms of taking these medications. But I agree with Ms. Martello that any program put in place like this should assure that it doesn't interfere with the appropriate prescribing of these medications, the appropriate dispensing of them, and that patients in pain are able to get them. And I think the agency itself is struggling with what that right balance is right now for these extended release and long-acting opioid products.
Thank you. And to Ms. Martello, you state, and I agree with you, that you do not want to see barriers to patient access for needed prescription medicines. You highlight one potential barrier could be unnecessarily restrictive drug control regulations and practices. Could you give us in a little greater detail what you mean by that?
I think healthcare providers play a pivotal role in helping to ensure that patients have access to the medicines that they need, and so we'd want to have healthcare providers and pharmacists, frankly, to be part of this conversation to help ensure that they can work with patients and counsel them on medication management and using medicines appropriately as prescribed.
Thank you. And to General Dean, first of all, thank you, sir, for your service to our nation. Have you seen greater abuse given the fact that we now have military operations in the field in both Iraq and Afghanistan? And has there been a tracking of this in relationship to other times when we have had our military personnel in combat situations?
As you know, I've been retired for a few years now. So
yes, sir.
I'm giving you information from my perspective and not from within the Department of Defense. But clearly, the protracted wars that we've been in and the extensive number of severely wounded soldiers and other members of the armed forces have contributed to an increased number of them needing and benefiting from over a long period of time for these medicines. And as a result of that, it is clear, and my friends have told me, that there are an increasing number of them who unfortunately are now abusing them. And they are trying to find ways to combat that. Just recently we had an officer as senior as a 3-star general admit that he was addicted to painkillers, pain medicine. So it is an issue. I'm not actively involved in it now. I'm looking to work with the military services to help them build some procedures that would get at training and education around military bases that would help combat this. But it is a significant issue.
Thank you very much. And Madam Chair, I yield back my remaining 4 seconds.
Thank you for your generosity. Recognize myself for 5 minutes again and say that it's so unfortunate, General, that we're hearing that this is truly carrying over into our troops, and it just really makes a huge punctuation point on how important it is that we're doing this here today. So I thank you for your testimony and for being here. Quickly, just to point out, though, that the FDA does not currently have a REMS program for long-acting and extended-release opioids. So it is not currently in place, and I am wondering how long it will take for them to do it and how many deaths will it take for them to do it. And I'm curious, you know, fen was taken off the market really quickly. If either one of the two pharmaceutical reps can explain to me the difference, why fen would have been removed from the market, or some of these drugs that are so quickly, and what the difference is between that and these opioids that are now up to tens of thousands of deaths a year.
It would be inappropriate for me to substitute my judgment for that of the independent scientific expert agency, the FDA, which evaluates the safety and efficacy of all marketed medicines. And so from my perspective, I think it would be inappropriate for me to comment on that.
Okay, fine, then let's move. Let me use my time with somebody who can actually comment, if that's all right. Mr. Clark, and any of you, can you explain to me why the abuse of opioid drugs became a problem so quickly? The trend lines screaming up there. Anybody who's out there in the field, in the real world?
I mean, I think there's probably a combination of factors, and clearly supply has been a factor. I think the environment of marketing, direct-to-consumer marketing in the pharmaceutical industry has expanded the abuse of prescription drugs, not just prescription opioids.
In fairness, I have never seen an advertisement ever for OxyContin.
That's correct. But my point is that the direct-to-consumer advertising, and I think there's a fairly robust literature on this now, is creating a sense of a reliance on medicine to address a variety of different ills. And so we see in our research, which I mentioned, and Dr. Boyd sees the same thing, an increasing reliance on the part of teens, at least, to be addressing not just to self-medicate or recreate with these substances, but to address life management issues. And I think that is linked in some measure, not entirely, but in some measure, to aggressive marketing.
Thank you. Does partnership have any explanation, just from observing standpoint, of why rogue pharmacies specialize in hydrocodone versus oxycodone or other controlled substances, yet the pill mills specialize in oxycodone instead? Has anybody figured out that discrepancy?
I don't have an answer for you on that.
Anybody know that answer? Okay. Mr. Mayor, with the Take Back program, what do you see as the key features of a successful, always available program?
Local community support, education is going to be the biggest key. Letting the communities, the public, know that there is a sustainable take-back program within their community. The program that we put together, the countywide program, which is in our county actually, was a combination of news media and support from local newspapers, but it was also putting flyers in the pharmacies, letting individuals know when they pick up their prescriptions that they can dispose of unused, expired at the local law enforcement agencies.
Terrific, thank you.
Education's the key.
Okay. Dr. Koster, when you see the statistics and graphs that Governor Scott presented earlier showing the disproportionate share of drugs dispensed from Florida and national statistics on drug diversion, do you think that the DEA and FDA quota system needs to be reevaluated in light of the high percentage of diversion, particularly in Florida?
Well, I know the way the quota system. I'm sorry. I know the way the quota system works now. It's based on I think a combination of factors, both in terms of what the data show in terms of demand, FDA data and other data that feed into DEA, and then DEA then determines how much our individual manufacturers can make. In terms of the situation in Florida, it sounded like part of the issue down there was that they didn't have a prescription monitoring program, which hopefully that will, deter some of the abuse. But we're happy to talk with the committee and the DEA about whether the system needs to be recalibrated.
Let me just back that out. I'm sorry, I'm down to my last 15 seconds. You just said the quota is based upon the demand?
No, I understand that, but
isn't that the problem here? The quota, are they? If anybody wants it, then they're allowed to make it. That's as simple. That's it. That's the way you just explained it.
Well, again, I'm not intricately familiar with how the DEA determines its actual quota, so I just gave you a broad overview. So as I said, maybe it's time that that whole system is looked at again in terms of how those quotas are determined based upon what's happening in the state.
Thank you, Doctor. All right, Mr. Butterfield, you're recognized.
Thank you. Let me drill down on prevention for just a moment, if I can. If we can prevent abuse, we know we can save millions of dollars, and more importantly, we can save many, many precious lives. As prepared by the Office of National Drug Control Policy, the 2010 National Drug Control Strategy calls for federal, state, and local entities, as well as non-governmental partners, to seek early intervention opportunities in healthcare. One of the opportunities that the strategy highlights is working with physicians to achieve consensus standards on opiate painkiller prescribing. Mr. Clocklin, I'm going to go back to you. What do you believe are the best ways to seize this opportunity? How specifically should stakeholders unite around consensus standards? For example, should task forces or working groups that include doctors, nurses, pharmacists, and others be created? What role can the partnership play in such a process?
I think we've heard a lot today pointing to the need for prescriber education, first of all, on appropriate prescription of opioids and other medications. One of the measures that the partnership supports is the explicit linkage of education of prescribers to their DEA registration renewal every 3 years. So I believe that's an important piece, and it's one that Director Kurlikowski also cited when he spoke here earlier. I think the dialogue, too, between healthcare professionals, whether they're prescribers or pharmacists, the dialogue between those healthcare professionals and consumers, particularly parents, needs to be much more mindful of the risks of abuse, the risks of addiction. And I know one of the pieces that's under discussion as part of the long-term opioid REMS is, and one that the partnership supports, is the adoption of effective prescriber-patient agreements at the point of prescription, so that the patient very clearly understands the risks. First of all, there's a screener so that the doctor is aware if the patient indeed is particularly susceptible to addiction. But the patient is also aware of the risks of abuse, the risks of addiction, and the need to effectively safeguard meds, dispose of them appropriately.
Well, perfect timing. We've just been called to the floor. You heard the buzzer. I'm going to have to yield back. Thank you.
I thank the gentleman, and does the gentleman from...
I do not, Madam Chair, have any more questions. I yield to you.
I thank the gentleman for yielding back, and believe that we should wrap this thing up. Before I do, I'd like to ask unanimous consent that these 4 items that we have previously discussed with the minority be included in the record.
No objection.
I thank the gentleman. And we also have statements from members who are not on the subcommittee that will be submitted for the record without objection. And so I just wanted to say that as we wrap things up today, I want to thank all of our panelists, as well as my colleagues and their staffs, for their time and the commitment to this critically important issue. If 30,000 Americans died every year from food poisoning, Congress would take action. If 30,000 Americans died from pesticide exposure, Congress would take action. And if 30,000 Americans died in airplane crashes every year, trust me, Congress would take action in a huge way. So why are the victims of prescription drug abuse treated differently? I don't have an answer, but I encourage everyone here to help us find one. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to please respond promptly to any questions they receive. Again, I thank you all. I look forward to our work together in the future. The subcommittee hearing is now adjourned.